I think this is very important and always ignore topic. Everyone is practicing the treatment of UTI, and for the simple doesn't matter, but the day duration, the proper dose, these are all missing. And the newer antibiotics come in focus, they start it without knowing, considering the consequences, what it is producing in the society, in the treatment protocol as a whole. So here is a small part of the treating the UTI, but important to make the people aware, to make our students aware, to make our faculty who are practicing off and on this UTI problem. And these are potentially curable conditions, provided we search for it, we give some time and patience to know the things. So I think they are all well qualified teachers and the students are very, progressive. I wish them all the best and please start the program.
Thank you, sir. I have the pleasant duty to introduce the today's expert, Professor Ranjit Kumar Das. She was the ex-HOD of Urology, Arjikar Medical College. Before that, he was in IPGM here for long years. And truly speaking, he has many students. They have become teachers now with great repute. And today, welcome you, sir, for this program.
Thank you, Dr. Day, for this kind words.
And Dr. Anshuman Asu, I remember in the 2019 AGM, he raised his voice against the no opportunity for the juniors in participation in the association's activity. I hope that this now he doesn't have any such feeling about the association, because this year I have compiled the teachers panel in such a way both the experience and the newer blood has come into the forum. So, and for Dongshu, he is presently the consultant in Paras Hospital and also the DNB teacher. And hope I know him for many years since I remember for the last 5-6 years, of course, I know him. So he is very progressive urologist and teacher, and I will request him to start the today's program right in time.
Thank you,
Over
sir.
to Anshu.
Thank you, sir. Thank you very much. Good morning, everybody who is present here, all the students and all the teachers, all my colleagues who are present here in this session. It is a privilege for me, as I told, he has given me this opportunity for the second time in 2 consecutive years to moderate this session on genitourinary infections. Last year also I was the moderator, and we are going to do a comprehensive discussion over the GU infections. We will be discussing 3 cases for case discussion, and then I'll be presenting one presentation on interstitial cystitis. So this is the agenda of today's meeting. To begin with, I would first like to introduce the teachers. I think we have Dr. Joy Narayan Chakravarti, who I see is online. We have Dr. Rajiv Ranjan, Dr. Sanjay Chaudhary from Odisha, and Dr. Professor Animesh Das. I am not able to see whether he has already joined or not. But we will go ahead with our program. The students, I would like first them to introduce themselves. Please, Dr. Anshu Kumar, introduce yourself. Are you available?
Yes, Anshu is available. Anshu,
Dr. Anshu Kumar, please introduce yourself. Please. Dr. Zaid Imbisat, are you available? Dr. Abhilek Tripathi.
Yes, sir.
Please
Yes, sir.
introduce yourself, Dr. Abhilek.
So myself, Dr. Abhilek Tripathi from SB Medical College, Cuttack, Odisha. I am 3rd year urology resident.
Okay. Dr. Asim Kumar Das. Dr. Asim Kumar Das, are you available? Okay, so we will go ahead with Dr. Anshu Kumar and Dr. Avilek Tripathi. I think they are available. What we will do, I will be presenting the case capsule here. The case will be presented by me, the history and all those things. And the teachers, Dr. Joy Narayan and Dr. Sanjay, I can see they are online. They will be asking questions one by one to all the students simultaneously. Only one student doesn't need to answer all the questions. It should be, the opportunity should be given to all of them to answer questions sequentially. So with the permission of the chair and permission of the teachers, I would like to start the first case discussion.
Yes, please go ahead.
Yeah, please go ahead.
Sir.
Share your screen.
My screen is visible, sir.
Yes.
Okay. So this is the first case that we are going to discuss. Dr. Avilek Tripathi and Dr. Anshu, please listen carefully, sir. I'm starting the presentation.
Yes, sir.
This is a my screen is visible.
The screen is visible,
Complaint.
but only case discussion is written. Case is not coming on the screen, main screen.
1 minute, sir.
Details are not coming on screen. Yeah. No. Back to pavilion.
Sir, just a minute.
Yes.
Now it is
Yeah,
coming.
it's fine.
Yes, yes, yes.
Okay. So this is a 32 years old male who was presented to us in the OPD with the complaints of increased frequency and nocturia for last 1 year. The daytime frequency is around 15 to 20 per day, and in the night time he has to wake up for 10 to 15 times per night to avoid urine. He also complains of urgency and urge incontinence for the same last 1 year. There is sensation of burning during micturition, almost for the duration, and occasionally he has complaints of right flank pain as well, which is dull aching in nature. In the past, he has had history of one episode of hematuria 4 years back, which was controlled with conservative management. There is a history of cough for 5 years, 5 years back, for which he had to take a prolonged treatment at a government hospital. There is no history of hypertension, no history of diabetes mellitus, no history of thyroid disorders or any other medical comorbidities. There is no even any significant surgical history. To continue in personal history, he is addicted to BD smoking and is a non-alcoholic. His bowel habits are within normal limits. And he has no significant family history apart from a few contacts of tuberculosis in his family and in neighborhood. Coming to the examination.
Dr. Anshu,
Sir,
Dr. Anshu, please
Sir.
stop here. Let the teachers cross up to this point of history.
okay,
Then,
sir.
you,
Okay.
as per their demand, we will go further.
Okay, sir. So Dr. Joy Narayan sir and Dr. Sanjay sir, you can ask questions till this point, sir.
Dr. Anshu, can you please come to the first slide?
Sir,
So, thank you. So, Dr. Avilek and Dr. Anshu is there? Am I audible?
Yes, sir. Yes, sir.
Yeah. So, right from the beginning, the chief complaint of these patients is before you.
Yes, sir.
So, what do you think in your mind that how to approach this patient right from the beginning? He is having these symptoms. What is your thought? what you think this
So-
can be from the chief complaint?
So this could be, sir, urinary tract infection, sir. And so I need to,
Tract infection, right?
yes, sir. Yes, sir.
Okay. So the
So I would
first
like
thing
to
comes to mind, it is urinary tract infection,
Yes, sir.
right? Next. Anything else or
So I want to know about there is a fever or not during this last 1 year. What are the episode of fever? And so, is there any evening rise of temperature, or sir, there is a wet loss or not?
yeah, we will come to the point. What I want to say is because when a patient you see first time, you have to think something in your mind so that you will subsequently you will ask something to Dr. Ansuma, right? So only urinary tract infection or you will think something else.
First will be the urinary tract infection only, sir. Okay,
Okay.
sir.
Dr. Angshu, Professor Animesh Das has joined just now.
Yes, welcome, sir. Good morning, Professor Animesh Das, sir. We have started the first session, and Dr. Sanjay is asking questions. You can join in, sir. Please go ahead, sir. Dr. Sanjay, sir. You can continue.
Dr. Abhilek, what I see is urinary tract infection, the first symptom will be a fever, high grade fever, with chill and rigor, but there is no fever or chill and rigor.
Yes, sir.
You see complaint?
Yes, sir. Frequency and nocturia for 1 year. Daytime and nighttime frequency of 15. Yes, sir.
Yeah, any other disease you will be suspecting so that accordingly you will ask some leading question to the patient.
So actually, nighttime frequency is very much on the 32-year-old male. So,
Yeah.
and there is a history of taking long treatment 5 years back. So I would
Yes.
reflect upon on the tuberculosis, sir.
Okay, my one question will be, last question to you will be, can benign prostatic hyperplasia in this patient lead to these symptoms?
But sir, age is not contributing to that BEP, sir. 32-year male, less likely to be.
Okay, please, Dr. Joy, please take this.
Yeah,
Over to you, sir.
thank you, sir. For the students, I want to ask just one question. What do you think is the normal daytime frequency and normal nocturia for a normal person?
For
Yeah,
normal processor, daytime frequency should be 3 to 4 times, and there should be no nocturia. Even a single episode is present is termed as nocturia.
Yeah, you are right. Quite, it's the daytime frequency should be 4 to 7. Nocturia is 0 to 1. That is a normal
Yes,
issue. Number one. Number two, here there is burning micturition. That means the dysuria is there, and the patient is
sir.
having symptoms for 1 year. So,
Yes.
to suspect a case of something long or chronic infection,
Yes, sir.
night sweats, weight loss, are these very common?
No, sir, they are not common. They are particularly for the tuberculosis and lymphoma, sir.
So, you heard about night sweats and this weight loss in case of pulmonary or extrapulmonary tuberculosis. That we have not come to the diagnosis yet, but is it very
These are
common?
the three symptoms of tuberculosis. Maybe or pulmonary or extrapulmonary, so both.
These are common in pulmonary tuberculosis, and extrapulmonary tuberculosis, night sweats and weight loss are very, very uncommon. So,
Okay.
what are the other history would you take from the patient? Any other extrapulmonary or any other extragenital genital organs which may have, which is the most common during examination? What will examine? How will you examine this patient?
First, I will go for general examination. In that, I will go for the if there are any palpable lymph nodes or not. Is there any sinus present or not? Genital sinus. If this will be the same general examination. In the local examination, I will see for the any sinus beaded bars. If I'm saying it to be a tuberculosis, also on DNS there will be a prostate, might be of abscess, also some nodularity, also camera may be palpable.
Sir, when you suspect a case to be a genital urinary tuberculosis, the most important thing you have to examine is the scrotum. Epididymis.
Yes, sir. Yes.
So, have you asked about the patient whether he is having a chronic heart swelling near the epididymis, which is not responding to medical treatment?
Pardon, I didn't get your question.
Yeah, go ahead.
Okay, in the history we have completed, now we will come to the examination part. On general examination, as Dr. Tripathi was asking, it was within normal limits. On systemic examination, para-abdominally, there was no significant finding. Respiratory system, CVS and CNS all were within normal limit. The genital examination, the penis and external meatus was normal. The urethra felt was normal. The scrotum and bilateral testicle were normal in size. There was no thickening of any mass or anything. On DRE, the perianal skin was normal. The anal tone was normal. The prostate was flat. The overlying rectal mucosa was mobile, and the returning finger was not blood stained. Sir, this completes the examination, sir. You can ask questions. The other students also, I can see some of them have joined. Dr. Anshu, Dr. Zahid, you can also answer the questions. You can come ahead.
So up to this, Dr. Avilek and others,
Yes, sir.
can you summarize in 2 or 3 lines?
Yes, sir. 32-year male present with a 1-year history of nocturia increased frequency during daytime and nighttime. And so patient also gives history of taking long treatment 5 years back. And so there is no other any contributory history. Physical examination roughly normal, sir. And local examination is roughly normal.
So Dr. Joy has already asked you during a general examination of the patient,
Yes, sir.
if you are suspecting a patient of suffering from any chronic diseases, right?
Yes, sir.
So can you enlighten some chronic disease in our genitourinary system?
Hello.
Which will
Hello.
do this symptomatic presentation and your
Hello.
First chronic will be the tuberculosis itself.
One is tuberculosis, that is genitourinary tuberculosis.
Hello.
Okay.
Hello.
Other will be the diabetes mellitus would be present, sir.
Hello, Anshu.
Sir, yes,
Dr.
sir, you are
Anshu.
audible, sir. You can ask questions, sir. Yes, sir.
Dr. Anshu,
Yes, sir. Professor Animesh Das, sir, please.
can you hear me?
Yes, sir. Yes, sir.
I mean, this was the, I saw that you have presented the history and the examination. And so from the history itself, what does I want to ask the candidate, what do you think, what comes to your mind? I mean, what are the possibilities?
So first, the urinary tract infection.
ঠিক আছে, সামনে problem হচ্ছিল, ঠিক আছে. Yes, UTI, and then?
And so second will be the genitourinary tuberculosis.
Yes.
Okay, with the permission of the Animesh sir, I request that other students should involve and let them participate one by one so that they will have single diagnosis by per head.
Dr.
Abhilek,
Anshu,
let
differential diagnosis till this point.
all have joined, I
Hello.
think.
A 32-year-old. Hello, Abhilek.
Yes, sir.
Can
Yes,
you
a
tell me?
32-year-old patient
Yes, sir.
with urinary frequency, nocturnal, diurnal, and having dysuria.
Yes, sir.
And so I was asking, what are the points that you come to your mind? What are the differential diagnoses? What are the possibilities? You said UTI, genitourinary
GATT.
tuberculosis.
Hello.
Yes, sir. As the, sir, there's no mention of the stream of the urine, but if I'll take that into consideration, then strictly can also be
वो
the
जो हेडफोन था वो कहाँ है? जो हम तेरे को दिए थे एक बार
A
तेरे बैग में डाल
32-year-old
दे।
patient, can it be anything else?
उसका आवाज ही नहीं जा
Say,
रहा। हेलो
hello.
हेलो
yes, sir.
हेलो हेलो
I think I'm having a bit
Hello.
of audio problem.
हेलो
Sir, you are
I'm having
very much
audio
audible.
problem.
Somebody else is disturbing it. You can go ahead, sir. Your audio is
তোমার
audible.
কি এ হবে কিছু পড়ছে তো আমি কি করবো শোনা যাচ্ছে না। আরে বাবা হচ্ছে না তো কি করবো
Dr. Anshu, please go ahead. We are getting behind
Hello.
time. So you should request
কি বলো
Dr. Das to mute himself for a while. Dr. Das, please mute yourself for a while.
আরে আমি ওনাকে ফোন করেছি রে বাবা তুমি বলো গোলক বাবুর সঙ্গে ওদের কথা বলতে আর আমি একটু
Dr. Das,
মিটিং এ
please
আছি
mute
আমাকে ডিস্টার্ব
yourself.
করলে তো মুশকিল হ্যালো
See, let me come in, sir. Actually speaking, by looking at the history and clinical examination, the question asked to the postgraduates is there what are the possible differential diagnosis in this case?
I can see Dr. Zayed is available. If he can take the question, Dr. Zayed, tell the differential diagnosis till this point. Dr. Zayed, are you available? Unmute yourself.
Okay. Hello.
Yes, Dr.
Am I-
Zayed, you can take the
Am I-
differential diagnosis till this point. Yes, you are audible now.
My first differential diagnosis would be genitourinary tuberculosis. Other differential diagnosis would be urinary bladder calculus or carcinoma in situ of the urinary bladder, which may also present with dysuria and increased frequency. So,
Very good. Another thing, chronic prostatitis, can it come in the picture?
this is chronic prostatitis.
Yeah. Now, how will you proceed in this case?
Yes, sir. Prostate should be examined, sir, and the prostate, we should examine the consistency of the prostate, the size of the prostate, tenderness of the prostate, and whether there are any nodules present or not. We should look for these features of the prostate, sir.
Sure. Any other thing? Now, how do you proceed seeing the overall history and clinical examination? Now you have got a little bit of idea that it's the both day, night and night time frequency is there, and
Yes, sir.
patient is uncomfortable, dysuria is there, and it's chronic. Since 1 year the patient is having all this, there is no night sweats. Otherwise, the patient is to some extent in healthy state. Now, how will you proceed in this case? It means that how will you approach in this case regarding diagnosis? That these are the in your mind that these may be the differential diagnosis. And now, how will you clinch the diagnosis? What are the steps you will go step by step?
After history and examination, I would like to do urine examination, sir, urine routine and microscopy and urine culture, sir.
Very good. Yeah.
And
Now here is the investigation.
Here are the findings or investigations. what is your take now, Dr. Zahid?
Serum creatinine is raised, sir. So we will have to, and in urine routine, sir, there is urine culture is sterile, and urine routine is having lot of pus cells in acidic urine, and also microscopic hematuria is there. So it is a case of sterile acidic pyuria, sir.
Very good. Very good. Excellent. Sterile acid pyuria. Yeah. Now the next step.
And
What are
Can
the
you
causes of
enumerate some
sterile
causes of this sterile acidic pyuria?
yes, sir.
Can you enumerate some causes of this sterile acidic pyuria?
Yes, sir.
What are
This
the
is
other
sterile
causes?
acidic. Yes, sir. Apart from genitourinary tuberculosis,
Hello.
this is hello. Yes,
Hello.
sir. Am I
Can you
audible,
hear me,
sir?
sir?
Yes,
Am I
yes, you are audible, Dr. Zahid. You continue.
Yes, sir. Yes, sir. Apart
Go
from
on, go on.
genitourinary tuberculosis, this sterile acidic pyuria could be seen in stone diseases, in calculus of genitourinary tract, and in malignancy of the urinary bladder. Also, we can get cancers of the urinary bladder. We can get sterile acidic pyuria, sir.
Other causes of the partially treated infection, inflammation of the urinary tract, sir. And so in chemical cystitis also we can get sterile pyuria, and the cystosomiasis also we can get sterile pyuria.
Right. Now, what will be the next step?
I will go for the urine AFB and urine culture for the AFB. For 3 to 5 days, urine AFB for 3 to 5 days continuously.
Now stop. Now stop. You have told that now you will go for the urine microscopy, smear, and urine culture. Normal.
Urine AFB, urine for AFB.
Urine for AFB. Now,
Yes,
what
sir.
urine for AFB?
This is
Culture
the
or smear?
See the mycobacteria, sir, in the urine, in the first white sample of in the morning.
How many days will it take?
So for
the
3 to 5 days, we have to sand it.
How will you collect the sample?
So it should be the overnight sample, preferably 8 hours, and this should be the first white sample.
Do you think a person who is voiding 10 to 15 times per night will be able to give you an adequate sample?
No, it's not
in the first
possible for
void?
that person, but still we can, if possible for 2 hours, if at least for 2 hours.
So he is voiding 24, 25 times per day. It means he is voiding every hour. How can you
Really,
say
yes,
that
sir.
he will be controlling his urge for 2 hours? Will he be able to do so? What can be done? What can be advised to the patient? See, sample collection is very important when you are diagnosing TB. So, this you should know. How, and this is a very practical problem. We always, in the books, it is written the first white sample, and we ask the patient to collect the first white sample. It is too low in quantity so that an AFB can be seen in that.
See, Abhilash, now you are just indicating that you should send the sample for centrifuge and then smear as well as urine for AFB culture. Now, are these the standard procedures to be done right now? What's the WHO guideline now? And what is the sensitivity and specificity of urine microscopy and smear for AFB as well as other tests? What's the WHO guideline at present, right now?
So for urine for AFB, sensitivity is 85% and specificity is 90%, sir.
See, it's only 40 to 50% microscopy. It's a positive, and specificity is 100% if the AFB smear is positive. Acid first bacilli intracellular. But more than 90%, both are 96% to 94% sensitivity and specificity. And according to the World Health Organization guideline, at present, it's the gene expert.
Yes, sir.
Gene expert, that means PCR for tuberculosis. The morning urine we have to send, and that is the first thing we have to utter before telling this urine microscopy for this detecting MTB.
Okay,
For
sir.
urine microscopy, you have to send to say that I have to look for some other associated infection. Mycobacterium tuberculosis infection may be associated with some secondary infection. So these can be diagnosed with routine microscopy and routine culture. What we have. But if you suspect that something that tuberculosis, then gene expert is the first thing.
Okay.
And regarding the culture, now liquid culture is the standard of technique according to the WHO guideline. It's no more that I will send the urine for AFB smear and AFB culture. AFB culture will take 1 month. Remember
Yes,
that. It will take 1 month. And gene expert, the report will come within 2 to 4 hours.
Yes,
And
definitely.
last point for gene expert is that at the same time it will say whether it is rifampicin positive or negative. So you will have an idea that whether it is a
Resistance.
not MDR gene at the same time.
Yes, sir.
Is it okay? Yeah.
Yes, sir.
Other
Why, sir, I want to ask, why do you take the first morning sample? Why not the day sample can be taken? What is the
Actually,
idea
sir,
behind
this
this?
tubercular bacteria is secreted intermittently. So if we have a large sample, then chances
Hello.
of detecting tubercular
Hello.
bacteria are high.
Dr. Anshu.
Yes, sir. Sir, can you hear me, sir? I am
Dr.
facing.
Anshu.
Hello,
Yes,
sir.
sir. Yes,
Can
sir.
you
Please
hear?
go ahead, sir.
Sir, can
Hello.
you hear me?
Can you
Yes,
hear me,
Dr.
Dr.
Anshu, we
Anshu?
can hear you.
Yes,
Sir,
sir. I
yes,
can hear you. Hello.
It's very. Can you hear me properly?
Yes,
Yes,
sir.
sir,
I can
Professor
hear
Das,
you.
yes, sir,
We can hear
you.
everybody properly. Don't get confused. Everybody is well visualized and well heard. No problem. Just go ahead.
Now, what I wanted to say is the students should know the basics, the urine smear for AFB as well as the culture. Maybe that is the what you said is the guidelines, but the standard textbooks still say that you need to go through these procedures. In fact, the gene expert definitely is a very good investigative procedure. But the gene expert, the real value of gene expert is when the yield of this thing is low. When the AFB yield is very low, it is sensitive for that. And where the culture is negative, that is, they are specifically indicated over there. And regarding urinary or genitourinary tuberculosis, gene expert is the first maybe for pulmonary tuberculosis, where you are examining the sputum. But regarding the genitourinary tuberculosis, it is a known fact that genitourinary tuberculosis gene expert has some fallacies, because the gene expert, the nucleic acids, there are inhibitants in the urine which can interfere with the examination of gene expert in urine. And also with gene expert, you cannot monitor the patient. Regarding the treatment monitoring of the patient, gene expert is not a right method. So not going into the arguments of this, I think the patient should know how to do a urine smear for AFB, how to do a urine culture for AFB, because especially examiners like me who is a bit old timers, we would like to know whether the candidate knows all these basic fundamental procedures. So I would like to ask the candidate, what are the steps? What is done in urine smear examination? How is it examined? How is the urine examination done in urine smear for Ziel-Nelson?
Anshu, you can take the question. You can answer this.
Hello.
Yes, you are
Yes.
audible. Please go ahead.
So in Jill stand, we stain we first make a smear in a glass slide, then we stain it with the Jill-Nielsen stain, and the in microscope we examine it in a high field microscopy. It shows
that
a
is
bright.
what I was asking. What are the steps? Do you know the steps of Ziel-Nielsen staining?
Uh,
Are you aware of the
sir,
steps?
sir, exact steps I could not remember right now, sir.
Anyone else? Any other candidate?
Hi, Dr. Abhilek, can you answer this question?
I don't know exactly the steps of this procedure.
You should know. You should know. As I said, it is very
Okay.
important to know. Even at this stage, it is important. So you should know these things. You have to go through all those things. So we will go ahead, sir. Professor Das, we will go ahead. We are short of time. So what further investigations you would want to do? Here the AFB was positive. Say it was positive.
Don't know.
The other blood investigation like ESR.
Yes,
Hello.
yes, sir was 27.
So we would like to go for chest X-ray.
If AFB was positive, even then we need culture, urine culture for tuberculosis.
So we will do a chest X-ray.
Okay, chest X-ray. This is the finding.
So in this chest X-ray on the left side, we can see some hilar lymphadenopathy, but we can't see any opacity in the upper lobe of lung. So the hilar lymphadenopathy indicates that there may be previous pox infection.
What is the importance of knowing that there is a previous chest in TB infection when your urine AFB is already positive?
And if urine AFB is positive, I would also
Does
like
it do anything for the management? There is already a history of tuberculosis treatment 5 years back. He had a history of chronic cough for which he had taken a prolonged treatment in a government hospital. It means that he has had a history of chest TB. So why is it important to know the chest X-ray?
The old focus of any tuberculosis, usually genital tuberculosis after 10 to 15 years after the pulmonary cough.
Already it is there. You
Focus.
have found out it.
Yes,
you have done the urine for AFB and it is positive. You have diagnosed TB. Now what?
Sir, if pulmonary tuberculosis coexist with the genitourinary tuberculosis.
Okay, go ahead.
For 9 months at least.
If you're thinking of a genitourinary tuberculosis, what you should do next after this investigation or imaging?
culture, urine culture for tuberculosis, sir. Urine culture for tuberculosis, sir. Only urine AFB is not enough, sir. Urine culture for tuberculosis is also necessary, sir.
So as per the criteria, major and minor criteria, already meeting the criteria. There is one AFB is positive, hematuria is present, a microscopic hematuria and ESI is present. So we can give a diagnosis of GUTB. So for further evaluate the function of the kidney, I would like to go for CT IVP.
Would you go for a culture first?
So already AFB is positive. So at culture, usually if solid media takes 4 to 6 weeks and liquid media 10 to 12 days. So better to start with the treatment. Because already meeting the criteria of major and minor criteria.
See, now MTB positive means acid plus bacilli positive means it may be typical, atypical.
Yes, sir.
Both give the same result. So we need a culture anyway. And the routine culture is done with the Lowenstein-Jensen media and that takes 6 to 8 weeks.
Yes,
now, again, I am coming to the WHO guideline. WHO guideline says that it's the now MGIT culture using the Willbrook medium. It's not the no more the Lowenstein-Jensen media is used. It's the Willbrook medium that is used nowadays, and the culture report will come in 2 weeks. the culture part I have gone, and now you are right in saying that now imaging. Now, what type of imaging would you like?
So I would like to go for CCT with CT urography.
Sir, creatinine is raised in this patient. We can't go for CCT.
Very good.
Creatinine is raised in this patient, sir.
What investigation you do want to do?
USG abdomen, sir.
Yes.
Next,
Very good. First, non-invasive is the USG.
USG abdomen, sir.
Yeah.
This is the USG finding.
USG is suggestive of hydronephrosis, and the visualized part of ureter that is also dilated. Lower part of the ureter that is not well appreciated, but the hydronephrosis and upper part of the ureter that is dilated.
In the third and fourth image, you can see the urinary bladder also. Can you comment on that?
Yes, a bladder, urinary bladder is also seen, and bladder
Small in
capacity
size,
appears
sir.
to be small capacity
Small in
bladder,
size.
sir. Bladder
Bladder-
capacity appears to be small.
I will not waste time on this. I will go ahead with the report. The report says there is a right renal cyst with parenchymal atrophy on the right side. There is grade 4 hydroureteronephrosis on the left side. The ureter is dilated up to the lower end. The urinary bladder is small in size and the wall is thickened. The prostate is normal size. Now, what next?
Yeah, dear Ashok, can you go to the previous slide, please?
Sure.
Yeah, now here it is right renal cyst. As you see here, right renal cyst. Now, is it actually cyst or something else? Can anybody, student?
Could be a
It
cut
can
of
be
calyx.
phantom calyx.
Cut of calyx, sir. Phantom calyx.
Very good. Once you find a cyst in the kidney with suspected tuberculosis, never utter that it may be a cyst. It may be a cart of calyx which has got distended. Okay, most of the time it is the cart of calyx. Yeah, now go on, please.
What next?
We will go for MCU.
Very good.
Small capacity bladder with hydroureteronephrosis left-sided.
Your MCU finding. This is the one film. Second film, the lateral film. Quality is poor. So pardon me for that. This is the third film. Can you comment?
Small size bladder with the bilateral view are more on the left side.
You completely described the MCU.
Yeah. Now, after looking at this MCU, it is evident that in bilateral there is grade 5 reflux. On the left side it has gone up, and on the right side the kidney is not visible here. So now, do you want to see any other anatomic detail of the kidney? Now, what next investigation would you like to do?
The urethra cannot be seen. I suppose it is all right.
Here the urethra can be seen in the lateral film.
Okay, that's fine.
Go ahead. What next? We are getting short of time. We have to complete it in next 20 minutes. So please be fast.
We can do NCCT KUB as well in this patient to get.
Yeah.
NCCT KOB was incidentally not done in this case. I don't have the report here with me, but say it's showed the same findings. The right kidney is atrophied. There is hydrocalicosis of the superior pole. The left side, there is hydroureteronephrosis, and the bladder is thick-walled and very small in capacity. So,
yeah.
Why did you say NCCT? What is the purpose? Why did you say NCCT?
if
What is the purpose?
Sir, if
Hello?
any calcification we would have missed, sir, on ultrasonography and plain X-ray, sir. We can find that detail, sir.
Yes.
And the suspicious focal dilatation of the calyx on the right side, sir, we could better delineate in NCCT, sir, what that actually is, sir. And appearance of renal cortex, we could also come to know, sir.
Yeah, now, how will you assess
Yes, if there are, you can also see if there are stones, associated stones are often
Yes,
there.
Yes,
You
sir.
can see in an NCCT scan. You can
Yes,
see
sir.
other features of tuberculosis if it is there. Any changes in the bones, any changes in the bones or lymph nodes, all these things which may be associated with genitourinary tuberculosis. Any calcification lower down in the epididymis, seminal vesicles, all these things, it is possible to know from an NCCT.
Yes.
Okay.
Now, what functional test would you like to do?
DTPA renal scan, sir.
DTP scan, sir.
Excellent.
Yeah, the report is there, DTPA renogram report.
The right
Go
side
ahead.
has GFI is very low, 4 ml per minute, and there's not mention of differential function, but it's less than 10 GFR. So the right side is not functioning, sir.
How do you calculate the differential function? Does it need to be given in the report?
No, not required,
So
sir.
we can just divide 4 by 56. We can get the right hand side the differential function and 52 by 56 then.
It is less than 10%.
10%, it's around 7 to 7.5%.
So since
Okay,
right side is non-functioning and the left side
Yes.
there is grade 5 reflux, so first we will try to save the left hand side, sir.
What you will do in the left side?
So we will plan for first we will start the ATT in this case, and then after 4 to 6 weeks we will plan for the reimplantation of the left ureter.
So once you start ATT, the whatever function the kidney is having, again that will be lost.
It will be reduced.
Why?
Because of the inflammation.
Before that, you have to secure the function of the kidney by some means.
So I will go for the, either we can put a DJ stent or we can divert the left system with PCN.
Yes. What I feel, what is the bilateral PCN which is necessary. After that, you should start the ATT. Either bilateral PCN and start ATT, and after 4 to 8 weeks of ATT, then you can plan your surgical management.
Yes, sir.
Now, what others may think about this? Go ahead.
Okay, sir said bilateral PCN. Why not bilateral stenting? Why does he prefer PCN over stent? What would be the cause?
Because it is already refluxing, and DJ stent could promote the reflux of urine from bladder to kidney, sir.
Again, it is very difficult to do in such a small kidney or retrograde stenting.
And
such a small bladder,
cystoscopy will be difficult in a small bladder. Cystoscopy will be difficult in a small bladder. The bladder gets overstressed, and that could lead to bleeding and hematuria in these cases of a small bladder.
And keeping two coils of stent simultaneously in the bladder will be very difficult for the patient. The patient will have too many problems, stent-related problems. So PCN is preferred. Okay, what next, sir? Dr. Joy, sir, please go ahead.
Yeah, it's a bilateral PCN which will save the kidney for the time being, and we should start the ATT. But at the same time, you should send the urine for resistance to the culture resistance for this seeing the analysis, whether it is resistant to normal anti-tuberculosis or it is a MDR tuberculosis. So we need a culture sensitivity test. And within this, by this time, we start the conventional anti-tuberculosis medicines, and within 1 month, the report will come, whether it is a MDR or whether it is a conventional. If it is conventional, we can continue with our this 4-drug, quadruple drug therapy. If it is MDR, then we may convert to our MDR regime. Now, regarding the surgical management, what do you think?
So as already we have diverted to the left system, I will go for the first nephrectomy of the right system because it's non-functioning, and secondly, it harbors, even after taking ATT, it harbors bacilli. So they have more chances of having recurrent infection with augmentation of the urinary bladder.
What is the capacity of the bladder?
So if we have to see if it's less than 100 ml, then usually augmentation is needed.
So would you do a cystoscopy in this patient?
Yes, sir.
Cystoscopy
we will do a cystoscopy in this patient, but with it will be a little bit difficult because we cannot feel
Cystoscopy,
the.
if you do a cystoscopy, plan a cystoscopy, you should do it under general anesthesia.
Yes, sir.
Not under local anesthesia.
Yeah.
Yes, sir.
Okay. And so what is your purpose for cystoscopy? What are the things you would look for while doing a cystoscopy?
So we have to look for any bladder lesion like ulcers, or we have to see the bladder capacity under general anesthesia. So we have to look for ureteric orifice, whether there is a periureteric edema or not. To plan surgical management, all these things are needed, sir.
Yes. Has cystoscopy been done in this patient? Has it been done?
So it was done, but the records are not there.
Okay, then yes. So now what next will you do? You have done cystoscopy. You have found that the patient has a bladder capacity of say about 50 to 100 ml, and there are bilateral refluxing A. There are no associated pathologies. So now what do you do? And has the renal function being repeated after the diversion, after the PCN?
No, sir. We don't have all those reports here, sir. Case presentation.
Okay, then go on. What will be the next step?
Let's go on quickly. We have to get it done in within 10 minutes now.
We will plan for surgery in this case, sir. First, nephrectomy with nephrouretectomy should be done in this case, and since the creatinine is high and bladder capacity is small, then we have to counsel the patient for the ileal conduit.
Will you do the right side first or the left side? Which side will you do first?
Already left side is diverted, so first we'll go for nephrectomy of right side.
Right side?
Yes, sir.
But you said, someone said that the left side is functioning, so we should
already put a PCN
do the
there.
left side first. The right side is practically a non-functioning unit. You have to save the left side first, the left kidney. So it's preferable that you try to save the left kidney first. So what will you do? What will be your plan?
The plan will be ureteric reimplantation, sir, with bladder augmentation.
In ideal situation, after starting the ATT, after 8 weeks, we have to re-perform our DTPS scan to see if there is an improvement. Sometimes there is blockage of the right kidney due to debris and all these things, and it may improve. It's not like that it's a 4 ml per minute GFR. It will stay like this. If the condition improves, then we have to preserve the right side as well. But if after 8 weeks, the DTPA scan shows that it is deteriorating or it is not of any use, 3 ml or 4 ml, then we can take a decision for right-sided nephrectomy along with the bladder resection. And in this case, the clam system, the clam augmentation system, the clam augmentation cystoplasty will not occur because the difference of bladder augmentation in non-tuberculosis and tuberculosis case is different. Case of tuberculosis infection of the bladder, once we have to augment the bladder, we have to resect the whole bladder except the trigon and bladder neck. We have to keep the trigon and bladder neck intact.
The disease parts.
Yeah, and resect the other parts of the bladder, and then we put something else to augment the bladder, depending on how much the bladder capacity was there, whether it was 100 ml, 200 ml, or less than 50 ml or 20 ml. Now it's open to discussion. Professor Das can throw some light on this.
No, that's quite right. As Dr. Janaran said, that you need to repeat the renogram before you proceed further, because there are instances where there may be some improvement in the renal function. That's right. But suppose the renal function is more or less the same. There is no difference in the renal function in a fresh renogram. So the plan would be, I think on the right side, you need to do an augmentation, and the the left kidney, at the same time, I think you should plan for a reimplantation. Or if you can save the ureteric orifice, you have to reimplant anyway because it is refluxing, it is a grade 5 reflux. So you have to do an augmentation cystoplasty, and you have to do a reimplantation of the ureter on the left side. But I would like to ask the students that how will you prepare? What would you investigate before doing this augmentation? What are the investigations that you would like to do?
First thing for the augmentation is that, sir, if the creatinine is more than 1.7 or less. If it is more than 1.7, then we can't go for augmentation as such. Then we have to go
3.5 in this case, sir.
2.56.
Yes.
It is 2.56.
Better to go for ileal conduit.
But after PCN, the creatinine may fall also. Na? So we will repeat creatinine after 4 or 6 weeks of PCN. If it comes down, then still the option of augmentation is viable option in this patient.
So as we said, we would like to repeat the renogram, the renal function. Okay, suppose the renal function comes down below 2. The patient's repeat creatinine is about 1.6 or 1.7. Any other things that you would like to investigate before you go for the surgery? What I mean to say, what are the investigations that you will do? You have said renal function, a repeat renogram. So what else?
Go quickly, please.
You'll be using a bowel segment, isn't it? So you have to be sure that the bowel segment is all right.
Yes.
So you have to do barium study or an endoscopy to see whether there is any inflammatory bowel disease or anything else, which may contradict your what you're planning. The other things that you have to know, the what is the liver function, the normal parameters, that so all these things you should know. So what are the augmentation? What will you do? What segment? What is your plan? How do you do an augmentation cystoplasty?
So first we will remove all the disease seg. First we will remove all the disease part of the bladder, except the trigonal area, and we will try to we will use the ileal segment.
Yeah, you are right. What are the options of taking a tissue, normal tissue, for covering the bladder, making the bladder? What are the tissues available to you, and which one will select, and depending on what? That is the main question here.
So we can take ileum, we can take part of a colon.
There are 4 segments here we can take. Number 1 is, you are right, ileum, sigmoid colon, cecum, and stomach. So out of these 4 structures, which one is most commonly used in case of tuberculosis augmentation? Is it ileum or something else?
I prefer to go for sigmoid, sir, because many times ileocecal tuberculosis may present at the same time.
Yes, this is number 1 cause. So we should not take ileum. And there is another cause for ileum, not taking ileum. It may be required later on.
For ureteric reconstruction.
Yes, very good. Sometimes 4 or 5 years down the lane, you see that the ureter has become beaded, and after tuberculosis, that was the most strictured. We need to replace the ureter also. So in that case, ileum will come into help. So there are 2 reasons. One, ileocecal tuberculosis may develop, and second, we need the ileal segment. So sigmoid colon is the most preferred segment for making the bladder in this case, in tuberculosis cases.
Yes.
So, Professor Das, you can throw some
Yes,
light on.
if there is tuberculosis affecting the terminal ileum, which is not very uncommon, terminal ileum or the ileocecal area, then definitely you will have to take another segment, and the most common is the left colon or the sigmoid colon. That's all right. But if the ileum is okay, free of disease, I think the ileum is preferable, because we are very familiar with the ileum. We use the ileum in many techniques, and also surgically also. There are some good points, like the amount of mucus production is very little with the ileum. The amount of metabolic abnormalities are comparatively lesser with ileum than the colon. And lastly, the incidence of malignancy, whether be it a conduit or augmentation, is possible in both the segments, but it is more common with the colon. So it depends. If the ileum is all right, free of disease, I would go for the ileum. But if the ileum cannot be taken, as said, then definitely the left colon or the sigmoid colon. Now, I would like to ask you, what is the, principle of augmentation? What is the principle of augmentation cystoplasty?
We are getting short of time. We
Why
will be
are you
closing
doing
in
an
5
augmentation?
minutes. We'll be closing this discussion in 5 minutes, sir. Please, students, go ahead. What are the principles of augmentation? Quickly, please.
I think the moderator decides what is to be done. So it is up to the moderator.
This
We should
question
go
has been asked,
depending
so
on
this
the
should be
time and
answered. This should be answered. This is a good question, and everybody should know this. Augmentation cystoplasty. What are the basic principles? Please go ahead. If anybody can answer.
Mr. Man,
Sir, yes, sir. Dr. Anvi, sir, please.
yes.
Good morning.
Can I contribute something in the talk whole we have finished total till now in the
Yes,
tuberculosis?
sir, you can.
Can
Please,
I?
sir, go ahead.
Okay. From the start itself in the history, it's not so clear cut in tuberculosis. They have they don't remember since when the problem is started. So very clear cut is not there with the patient. Usually don't say 1 year, 6 months like that. Second one, they have taken a lot of treatments before coming to you, and that history must be taken, that because he has taken partially treatment and most of the time. Third one, the findings of the PR examination in such a cases is never flat and no findings. So just we have to see the very carefully that the PR findings should be correct. Third one, the frequency volume chart in any case of in proportional dysuria and frequency should be taken, which will give the conscious capacity of the bladder, and many other conditions you can clinically find it out. So already he has less than 50 ml of the bladder capacity. And third one, we are trying of talking a lot of surgeries and all. This is in spastic stage, in infection stage. So once you start the treatment, some people add cortisone also, but should not be. And if this small, the bladder, if it's not diseased, it will come into shape and will need nothing. And in any case, you are treating with the ATT, renal failure patient, must be bypassed. Already discussed that TJ, you can't do DJ stenting in a small capacity bladder. PCN is the ideal one, and do the nephrostogram with that, and you will get the things where what is happening. CTJ must, DTPA must. We have already discussed all these things. And frequency volume chart after 1 month you take, it will be and there. And this arsine and this resistance with the drug is a must be now done to gene expert. Professor Das and we are old fellows, but we should have the know the new things and add it in the treatment. Gene expert and that sensitivity test must be done, must be sent and to know it. So these are the things we should, and follow-up should be longer period. You hardly will need the this augmentation cystoplasty, and once in a worst case you have to use the stomach, but frequency dysuria syndrome will be there. In the renal failure we don't use colon or the ileum and all. So it is the gastric segment which we are using, but patient will suffer, and you have to say the patient you will need CIC. After doing the augmentation, he may not pass urine properly. So you have to warn him, and he will take the soda bicarb tablet lifelong. So these are the things: metabolic, endoscopic checkup for malignancy, which Dr. Das has said, and these are the things, and long-term follow-up will be there. And of course, liver function, creatinine and hemoglobin should be done monthly and regularly to these patients. So these are the practical things which the student, when they go for practice or they know it, they go for exam, they will say it. And these are the things we wanted to just remind you all. You know, but failed to describe during the discussion. They are very good. Jayad and Joy has done excellent job, and I think we should go ahead. You can start the other case with permission of Dr. Das.
Yes, we will go ahead with the next case discussion. Let me share my screen again. Is it visible?
Yeah.
Okay. Go ahead. This is a 45 years old female who has come to our emergency with the complaints of fever for 5 days, which is high grade and associated with chills and rigor. There is a history of right flank pain for last 5 days, which is dull aching associated with sensation of fullness over the flank. nausea, and occasional vomiting. There is burning micturition with increased frequency and urgency. There is anorexia and generalized weakness. This is the presenting complaints. In past history, there is no history of diabetes. There is a past history of diabetes mellitus, which is she is on irregular medication for that. It is fully controlled. There is no history of hypertension, thyroid, or other medical comorbidities. There is no significant surgical history. She is a non-smoker and non-alcoholic. Her bowel habits are normal and has no significant family history. Sir, teachers, you can go ahead with questions now. Dr. Sanjay, Professor Das, and Dr. Joy Narayan, sir, you can go ahead with questions.
Dr. Ansu, please come to the first slide again, please.
First slide, yeah.
Dr. Jai and others.
Yes.
So who is the candidate? Who is the student?
You can ask Dr. Zaya, Dr. Avilek, and Dr. Anshu. Both, all of them are here.
So with this history, so what comes to your mind? What do you think this patient has?
It could be acute pyelonephritis, pyonephrosis, renal abscess.
Yes.
Yes. Well, definitely, it's an upper tract infection, high grade chills rigor with right flank pain. That means upper tract infection. That may be infection involving any of the kidneys. It may be pyonephrosis, pyelonephritis. You are very good. You were right in saying that. And the patient is also having burning micturition. Dysuria is there. And the important thing here is anorexia and generalized weakness. Have you noticed that?
Yes, sir.
Anorexia and generalized weakness. Now, another thing important here is for 5 days history, only 5 days. Okay. Now, next slide. Now, these are the comorbid conditions this patient is having. Diabetes mellitus on irregular medication.
Yes, sir.
Nothing else.
Yes, sir. So diabetic patients, they are already at risk of increased infections. So any infection could manifest in a fulminant manner in diabetic patients. And a patient was on irregular medication. So uncontrolled sugar levels, they are an important cause of rapidly increasing infections in the patients. So that's why patient is having, with this 5 days history, patient is this much symptomatic, sir.
Okay, that much of information is okay. It's only 5 days history. You are ill, and the patient is severely weak. Now, next slide. Continues. Non-smoker, non-alcoholic, bowel habits regular, and family history. Okay. Nothing.
Let us come to the examination. Her general condition is poor. She is toxic looking and febrile. Pallor is present. There is tachycardia and tachypnea. On systemic examination, on per abdominal examination, the abdomen is soft with localized muscle guarding in right lumbar region. There is tenderness in right lumbar region. A vague lump is palpable in right lumbar region, and right renal angle is full and tender. The other systemic examinations are within normal limits. How will you proceed?
Yeah, can you go to the previous slide, please?
That's it.
Yeah. Now, how will you proceed in this case? The information you are getting from the general examination, are these have got any importance in further prognosticating this case or in treatment? My question is to the postgraduates.
Yes, sir.
What are the information you get from here?
Patient is having signs of infection, sir. Patient is in the toxic look, febrile, and patient is having tenderness in the right lumbar region, and lump is palpable in the right lumbar region. Right renal angle is full and tender. So it could be, as the patient is diabetic as well. So it could be a case of acute pyelonephritis, or it could be emphysematous pyelonephritis as well, as the look is toxic, and it could be emphysematous pyelonephritis. Pyelonephrosis is still a possibility, sir, in this patient. So I will do investigations in this patient, urine routine, urine culture, and ultrasonography of the abdomen, sir. These are the first investigations I would like to do, sir.
I will add on with blood count also.
Yes,
This
sir.
came to you in the emergency. You are called in the emergency to see this patient. Now, what are the parameters you will look for? Just like we can't describe that this patient is having this. We need 6 parameters, and that is called a new score. Let us come to the previous slide. Have you heard about new score? It's everywhere now, all over the world, and India also. New score is used. First, the patient comes to the emergency. We need to see the pulse, temperature, respiration, systolic BP, SpO2, and alertness, mental status. These are the 6 things which will tell how much is the new score. Have you heard about new score? That the sheet is available in all the hospitals nowadays. It has become mandatory, new score. If it is 0 to 4, you can treat the patient in the ward. If it is 5 to 6, it's urgent. If it is more than 6, ICU treatment. So initially the sister, the nurse will tell you how much is the new score. So your first question to ask to the nurse, yes, nurse, how is the new score of this patient? And then you start treatment, and because these are the patients who need urgent and immediate treatment. But whether you will treat this patient in the ward, in the casualty department itself, or in the ICU, that depends on the new score. So remember this. The others may take on this issue. So this is the first thing in a urosepsis. This is likely a urosepsis case.
Okay. So should we go ahead with investigations? So these are the investigation findings. The hemoglobin is 7 gram%. Counts are raised with neutrophilia, urea, and creatinine are raised. Blood sugar is uncontrolled at 478 milligram per deciliter, and HbA1c is 8.5. The urine routine shows plenty of pus cells with microscopic hematuria, and the culture is CLI.
Yeah, previous slide, please. Yeah, thank you. Now, a question to the postgraduates. Sorry, hemoglobin is low. It's evident here. WBC is 21,500. DLC neutrophil 78. Urea somewhat raised. Creatinine is 2.14. It is raised. EGFR should be there. EGFR is not there. Now, serum creatinine has got no value or very limited value without the EGFR estimation nowadays. And blood sugar is very uncontrolled, 4.78, HbA1c 8.5. Now, question to the Indian MCH students: what is missing here? Any other thing you need in the investigation? Because blood is already sent.
LFT liver function test also I would like to do.
Before that, it's already a suspected case of urosepsis. Any other thing most important which is missing here?
Right.
CRP is there. Where is CRP? And platelet count. CRP, platelet count. And these are the 2 things. And blood culture is also absent. So now sepsis 6 bundle will come into effect into this. So once you see a patient in the emergency, we need to see the sepsis 6 bundle, and that is also worldwide accepted. And now thrombocyte count, why it is important, I will come to later on. And GCS score is also important because mental status is also important for urosepsis patients. Now CRP is absent here, mental status, as well as thrombocyte count. Now we'll come into the latter part of this case. Now, what other investigations would you, how will you proceed in this case?
So after this, we will like to do a ultrasonography of KUB region.
Yeah, very good. So it is
First, we will stabilize the patient. The counts are very high, sir, and the patient is being toxic. First, we will stabilize the patient. Once the patient gets stabilized, then we'll go for bedside ultrasound.
This is the ultrasound. What is the finding?
So we can see a crescentric shadow, crescentric hypoechoic shadow in the perirenal space, sir.
And hyperechoic area is also there in the renal, in the periphery of the kidney. The hyperechoic foci there also present, sir. Hyperechoic. So
what is it called?
This hyperechoic foci may be air foci.
Foci.
It may be air foci, and maybe a case of emphysematous pyelonephritis with fluids outside it.
There is a special terminology in ultrasonography for this finding, this hyperechoic shadow.
Posterior acoustic enhancement.
There is no posterior acoustic enhancement.
When do you see posterior acoustic enhancement? In what
In
condition?
stones, in stones we get posterior.
In stones, do you see posterior acoustic shadowing or enhancement?
Shadowing is there.
Enhancement when you get enhancement.
Yeah, when there is air foci.
Fluid. When there is fluid, then
you get posterior acoustic.
The reverberation artifact.
This is called reverberation artifact, posterior reverberation artifact, which is suggestive of air. Anyway, this was the USG report. Right kidney is enlarged, swollen with focal hyperechoic shadows with posterior reverberation artifact suggestive of air in renal cortex. Left kidney was normal, the urinary bladder was normal, and the other abdominal organs were normal. Now what? What next investigation are you going to plan in this case? How will you make sure that this is air?
NCCT.
Yeah, that's a good slide.
This is the axial section of the NCCT QOP region with normal right side kidney and left side there are multiple air foci seen with the distorted renal parenchyma.
Now, see, in this case, when you are shown a single film, always utter the term that this is a single axial CT scan film, and it is contrast enhanced and showing the mid pole of mid zone of both the kidneys. And I need to see the other films of the same CT scan series to have an opinion. But in this single film, it is difficult to categorize this patient. Now, what you have seen grossly in this case on the right side?
So right side kidney appears to be enlarged in size with multiple air foci in the renal parenchyma and in the perinephric space.
Renal parenchyma and the perinephric space. Now, what is this here? Any fluid collection have you seen anywhere?
Sir, posterior to the kidney, there is fluid collection, sir.
That is trending. That is not fluid collection. That is trending. Okay, that means perirenal infection is there, but trending. There is no fluid collection. Now it is intraparenchymal. Now you have seen air here inside the kidney. Now where is the air? It is inside the parenchyma, inside the pelvic alysial system, or outside the renal outline. Where you have seen the air? And is there any
the PCS also and the parenchyma also?
So for that you need to see he also kills. So here only you are getting one kill. So I don't think there is any PCS. Yeah, these are all intraparenchymal, and there is no fluid, I think, or less fluid outside. So now, Anshuman, you can proceed with your questions.
This is the CT scan reporting the right kidney is swollen edematous with fat stranding all around with air pockets in the renal cortex, extending into the pararenal space. That's normal. So we can go ahead with management parts. Professor Inmesh Das, sir, you can ask questions regarding the management of this case.
So, what will you do for the management? Any other investigations would you like? Besides all this, any other? This was only one film in a CT scan. Would you like to know the functional status of the kidneys, of the right kidney? The renal, the urea creatinine was raised, that's all right. But because the patient has sepsis, you can have a raised urea creatinine. But before undertaking what line of management will be proper for this patient, would you like to do a functional study, say a renogram, to know?
No, sir. First, I would like to stabilize the patient, and after that, if the patient, after that, when the patient is stabilized, then in later on we can know the function of the kidney, sir.
Well, this is, I think this is a part of management, because before you start your therapy, probably it is better to know what how the right kidney is functioning. So to complete the investigation and to complete everything, I think renal function in the form of a DTP renogram is would be good for this patient. Anyway, go on then.
Anshuman, can you show the CT scan again here? Yeah, here you see the interparenchymal gash. Now, whether it is this type of there are two types of EPN. It's an emphysematous pyelonephritis anyway, without any doubt. The left side is doing well with contrast, and the right side you have seen the interparenchymal gash, and that is extending outside. It is a perirenal, not pararenal. It is a perirenal. So, do you have any idea what is the type of gash here, and whether it is good or bad type? There are two types.
What is the stage? What is the classification of EPN? And what will be the patient? This patient, what is the stage of this patient?
There are two types of classification. In Huang classification, there are type 1 when the gas is in the pelvic ileal system only. In type 2 when it is in the parenchyma. Type 3A is perinephric, 3B is paranephric. And in type 4, whether it is in the either solitary kidney or simultaneously bilateral kidneys they are involved. That is type 4.
So whether
and
it
in
is
one it
yes, whether 3A or 3B.
it is 3B.
Why?
It is extending it up to the.
It is perirenal. It is not pararenal. Once it is pararenal, it is 3B.
It is inside the zerota. It is still inside the zerota.
Yeah, inside the zerota. It is 3A. And it is a mottled gash, intraparenchymal mottled and streaky gash. Whether it is good with no fluid. There is no fluid collection. It is the mottled and gash. And there is another type where there is flocculent gash as well as fluid. So which one is better? This type is better or that type is better?
So wet type is better. So dry type carry the more worse prognosis.
Yeah,
50 to 60% mortality in dry type for type 1. That is 50 to 60% mortality. In type 2, there is 20% mortality.
20%.
So it is type 1 or type 2?
Type 1.
Yes. So it's a good or bad?
Bad prognostics.
60% mortality.
Type 1 is bad type.
So your decision making depends on the type of gas collection here, Huang classification, and prognostic factors. So what are the 4 prognostic factors which will dictate your treatment? Now you have got one bad thing here, that is a type 3A dry type. And there are 4 prognostic factors. Can any one
Sir,
of them say what are the 4 prognostic?
thrombocytopenia, renal function impairment, shock, and altered mental status.
Excellent. Excellent. So here there is a deadly combination of this one, and how many factors are there? Thrombocytopenia is not mentioned here.
Mentioned, so renal function is impaired, and BP is most probably low in this case, sir. And patient or mental status is also not mentioned in the history, in the examination part.
Yeah, so these 4 prognostic factors and the type of the gas collection is most important. So here you can take is that there's one risk factor is there, and it's the bad type of gas collection. Okay.
Yes,
Now
yes, sir.
treatment part will start. Sorry, Angshu, I have to leave for airport. Thank you.
Okay,
Please
sir.
carry on.
Okay, sir. Thank you
Thank
very
you,
much,
sir,
sir.
for all. Das sir, Animesh Das sir,
Thank you.
professor.
Thank you,
teacher.
Jay. Okay.
Thank you.
Dr. Joy,
Yeah.
thank you very much. You very nicely conducted, I must say. And particularly this EPN case, you have added many informations, what is usually not in Campbell's. Thank you
sir.
very much.
Thank you, Dr. Joy Chakravarti, taking so much of pain for the teaching program of our zone, and hope in the subsequent session also we'll get your cooperation.
Thank you, sir. Thanks.
Thank you, sir. Sir, Professor Animesh Das, sir, if you would like to ask any more questions on pyelonephritis, or otherwise we will go ahead with the other case presentation.
No, how do you proceed?
Okay, sir.
Now, how do you proceed for this patient? So you have said that this is a high-risk case
So
of
we would,
right-sided emphysematous pyelonephritis.
so we
what would
will
you do?
admit the patient in ICU first. This patient need ICU care. So first we will start with hydration of the patient and try to maintain the BP. And if required, then we can add ionotropes. Next, we will add a higher antibiotic in this case. We will start with antibiotics. We will monitor the pulse, BP, general condition of the patient regularly. Urine output should be measured accurately in this case, and we will monitor the serum electrolytes. Then
Okay, that's all right. And after this,
after this, sir, we will
any surgical interference?
So after stabilizing the patient and quantifying the emphysematous pyelonephritis, we can put a bedside USG guided PCN or PCD.
Hello, I didn't hear you.
So we would
After
like
the-
to place a
after
PCD
the-
or PCN in this patient. So we will look for other blood investigation like PTINA, serology, and after that we will place a PCN or PCD in this case, USG guided PCN or PCD.
In this patient, where would you put the PCN?
Sir, we will have to look the other section in this case also. So most probably the perinephric space, there is a gas, larger gas shadow. So most probably we can put a PCD over there. But
Okay,
without
you would,
seeing the other
you would-
axial film, we can't comment about the size of the collection.
yes, that's right. You would like to see the other films also, and wherever there is a significant amount of fluid or air collection, whether it be in the parenchyma or in the perinephric area, you would place a PCN over there. And then, what is the percentage of improvement
And moreover, sir, we will like to control diabetes in this patient. It's really uncontrollable. 480 around sugar level is 480. So strict diabetic control is very important in this case, sir.
Okay, you have managed the fluid part, electrolyte part, the diabetes, the infection, antibiotics. And then how would you go further? Your treatment, how would you monitor the patient and
So we will monitor
how
the
would you
patient
monitor?
for higher mental status. We will monitor the patient vital regularly, blood pressure, pulse, respiration rate, if required, if the patient require oxygen support or not, iron support or not. We will just
So,
we will
okay, if
monitor.
suppose the patient is not responding to your treatment, how long will you wait?
Not responding to hydration therapy.
Not responding to your conservative management, how long will you wait? So these patients, if they do not respond, they have a high mortality rate.
Yes, sir.
Emphysematous pyelonephritis is a emergency. It is a urological emergency, a dire emergency. Previously, the incidence of surgery, the incidence of nephrectomy was very high. But today, with the more conservative approach and more vital monitoring and management of the infection and everything, the drainage of the kidney, the response to conservative management is much better. But whatever it is, you have to take a timely action. So I think if you see within say 5 or 7 days, if you see the patient is not responding, the leukocytosis is not coming down, the higher consciousness is not improving, your diabetes is not coming down, your renal function and everything. So I think you should take a decision, because if you are late, the mortality will also rise. So if the patient does not respond, I think you should take timely decision and go for a nephrectomy.
Dr. Sanjay sir, would you like to add something to this discussion?
Yeah. So all the postgraduates, so what will be the ideal antibiotic of choice for these patients? And the second thing is, for how many hours you will give these antibiotics, and how will you follow that antibiotic has not worked on the patient, so that you will take some another procedure? Because these patients are in emergency, we may lose the patient if we will not treat patient very delicately and with utmost care. So what will be your antibiotic of choice for these patients?
So I will
So
start with the broad
usually
spectrum
we start.
antibiotic, usually marrow with
One by one.
metronidazole, and we'll look for the vitals every too early, and we'll repeat the count. If the counts are going down, it means the patient is responding and patient is actually improving. If it is not improving, then we can go for the procedure.
So at the same time, we can send the blood culture and urine culture, and if we can get the sensitivity, then we can continue with that antibiotic.
No. The first problem is when the patient comes to you with a toxic condition, with higher counts in a septicemic stage, you have to choose a proper antibiotic so that within 48 to 72 hours, the counts as well as the toxemia of the patient should return to normal. So as the book recommendation is, up to 48 hours, you have to wait with your ideal antibiotics, but culture will give you a report after 72 hours. So you cannot
So,
wait for the culture report.
so
So give a proper.
we will start
Yeah,
with empirical antibiotic based on the institutional protocols.
right. Right. So the organisms varies from institutes to the organisms are the same, but the sensitivity of these organisms, it varies from the institute to institutes. So according to your institution protocol, you have to start a antibiotic depending upon the organism. So who are the organisms responsible for this emphysematous pyelonephritis?
So usually E. coli and Klebsiella.
Yes. So the sensitivity report according to institutes, you have to start the antibiotic immediately and follow for 48 hours. If the patient is not improving, we can plan for a PCD or a PCN depending upon the stage of the emphysematous pyelonephritis.
Yes, sir. We are getting short of time, so I think we will be going
Yes,
ahead
yes.
with
Okay.
our next case
You
discussion,
can
sir.
go.
Okay. The next case. Okay, is it visible?
Yes, sir.
Okay. So this is a 55 years female with who has presented to us with the complaints of again right flank pain for last 1 year on and off. The pain was dull aching. There is no radiation of pain. There is no bowel or bladder disturbance associated with the pain. There is sense of fullness in right flank for last 2 months. The fever is there on and off for last 2 months. And she also complains of burning micturition for last 2 months. On past history, there is history of recurrent episodes of UTI. There is history of diabetes mellitus. There is no history of any other or medical or surgical comorbidities. On personal history, she is a non-smoker, non-alcoholic. Bowel habits are not normal, and family history, there is no significant family history. Sir, we can go ahead with questions.
So this is the last case, I think.
Yes, sir. This is the last case, sir.
So all the PG students, please enumerate your differential diagnosis.
So my first provisional diagnosis in this case will be a stone disease with a close differential diagnosis of pyelonephritis, renal mass.
Wait.
And
Don't tell as a whole stone disease. You specifically enumerate your diseases 1, 2, 3, 4. Stone disease is not a correct provisional diagnosis. You have to tell an exact diagnosis.
right-sided renal stone.
Right renal stone. Okay, next.
It could be infected PUJ with infection. It could be the
PUJ with infected hydronephrosis, or you want to say infected hydronephrosis,
yes, sir.
right?
Yes, sir.
Okay, third one.
The patient is diabetic also, so I would like to add on pyelonephritis too in this condition, acute pyelonephritis.
Acute or chronic?
Acute and chronic, sir, because history of 1 year and on and off fever is present.
Okay, fourth one.
Renal mass.
It could be renal mass also.
Okay.
Yeah, GUTB
Anything?
also. GUTB also, lastly.
GUTB. Okay. So please, Dr. Ansu, come to the first slide again.
Yeah.
Okay, which of these diagnosis fits exactly to this chief complaint?
So renal stone with urinary tract infection, recurrent urinary tract infection.
My first differential diagnosis would be secondary UPGO and superimposed with infection, sir.
Okay. Okay, next. Go, Dr. Ansu, please proceed. So after this differential diagnosis, so examination, okay.
On general examination, pallor was present. On systemic examination, perabdominally, the abdomen was soft. There was no tenderness. There is a vague lump in the right lumbar region, which was bimanually palpable. The right renal angle is full but non-tender. Other systems were within normal limits. How will you proceed?
So in general examination, do you want some more information? You can ask.
Any lymphadenopathy present?
No, it is not present.
Patient on system examination per abdomen, there is no tenderness, but vague lump is present. Just bilateral terror. It could be as a mass also, general mass, or could be a POJO.
Will you speak close to your mic so that it will be audible better?
As on per abdomen examination, there is no tenderness. Right renal angle is full, so it could be as a POJO, or could be a renal mass, or it could be a cystic lesion of the kidney.
In your differential diagnosis, of infected renal cyst can also be added. With this examination finding, the first differential diagnosis that you all had said, can something be excluded? Can acute on chronic pyelonephritis present with this?
There's no tenderness is present, so acute pyelonephritis is unlikely.
Chronic pyelonephritis, usually the mass will not be lump, will not be palpable. Chronic pyelonephritis, kidneys are usually shrunken.
Yes, sir.
Okay, now how will you proceed?
I will go with the ultrasound as the extension of my clinical examination, and routine investigation, CBC, urea creatinine, urine RM, and serum electrolytes.
Okay. So the hemoglobin was 8 gram%. TLC was raised with neutrophilia. Urea creatinine was within normal limits. Electrolytes were normal. Blood sugar was 278 milligram per deciliter. Urine routine showed plenty of pus cells. Sugar was present, and on culture showed E. coli. This is the USG finding. The right kidney.
Right kidney, sir, there is a dilated
Both of these are right
calyces are present. Dilated calyces present, suggestive of hydrocalycosis, preferably, because it's not extending to QJ.
So we can see a grade 4 hydronephrosis with thin rod parenchyma and dilated renal pelvis in this film.
Anything else?
Can you find any posterior acoustic shadow here?
Yes, sir.
Yes, sir. We can find a posterior acoustic shadow in the. There is a post. Yes, sir.
Renal
What
stone
is
is
this?
also there.
There is renal stone.
What is this?
Shadow with a posterior acoustic shadowing in the renal pelvis. There are large dilated hypoechoic areas in the renal parenchyma. This is the USG report. Right kidney was enlarged, swollen with multiple hypoechoic areas with a large echogenic focus in the renal pelvis and posterior acoustic shadow. The left kidney was normal. Urinary bladder, it shows internal floating echoes, and other organs were normal. Now what?
Any of your provisional diagnosis fits to this ultrasound report?
So stone disease with infected hydronephrosis.
Okay.
Here in hydronephrosis, do you see any echogenic shadows?
So the report mentioned that there is some enhancing shadow in the bladder. So
Floating
most
echoes
likely-
are in the bladder. In the kidney, do you see the floating echoes?
No, sir, we can't see any floating echo in the kidney.
Do you think it is pyonephrosis? Does pyonephrosis look like this?
No.
It could be something else of that.
The infected hydronephrosis.
What is infected hydronephrosis? Anyway, how will you proceed? Say it is, you have said stone with infection. What next you will do?
Dr. Ansu and my teachers, can I leave now? I have some press conference in my apartment.
Yes, sir. Okay. You can. Professor Anmesh Das sir is here and Professor Ranjit Das sir is here. They will be asking questions.
If they
Okay,
permit,
thank
then I have
you
to
so much.
attend a press conference in our apartment now.
Bah, you have nicely conducted.
Thank you, sir. Thank you for inviting me as a teacher, and thank you all the faculties as well as students.
Thank you,
sir.
Dr. Chaudhary, for giving time for the zonal educational program. Hopefully, we'll get it once again in future when there will be further continuation of this program.
Yes, sir. This is a great effort from the zone as well as the USI and for all of you stalwarts of urology. And thanks, Dr. Ranjan sir, for inviting me as a teacher.
Welcome.
Thank you.
Thank you. Thank you very much.
Thank you very much.
These students, how will you proceed further?
I will go first. As university is normal, I will go first. City CUP or city Eurography.
So now what?
These are the axial sections of this contrast city, with the left side seems to be normal, and right side there are multiple
loculated connection
with a hyperdense stone in the pelvis.
What is your diagnosis now?
So is IVP pictures are available, sir?
Sorry?
IVP pictures are available. You can go for.
These are the only two pictures available. You can diagnose very well from these two.
It appears to be a case of polycystic kidney with a stone.
During the ultrasonogram, you said that it is infected hydronephrosis. So from the CT, what you are saying, do you still say it is an infected hydronephrosis?
On CT scan, the right kidney is enlarged, swollen with perinephric fat stranding. There is a large stone impacted in the renal pelvis at the PUJ region, causing hydronephrosis, and there are multiple hypoattenuating lesions in the renal parenchyma. And it is extending the perinephric space also, involving the liver, and posteriorly the psoas muscle is also involved. So any other diagnosis comes to your mind? Special type of infection of the kidney that is associated with obstruction.
Sir, can it be a case of XGPN also?
JU,
Tell me.
tuberculosis.
This is a case of
XGPN also.
You can see beer paw sign also here.
Beer paw sign.
There's multiple hypoattenuating lesions in the renal parenchyma due to an obstructing foci near the PUJ. It may be a PUJ obstruction or maybe a obstruction due to the stone. This looks like a case of an XGP extending into the pararenal space also, including the right fossa muscle as well. So how will you proceed in this case? How will you proceed, please?
So first we have to know the whether the kidney is functioning or not. If it is functioning, then
What will you do for that?
so we can go for a DTPA scan in this case.
Okay.
The right kidney, the GFR is only 3 ml per minute. And it appears that its less differential function is less than the 10%. So
How will you proceed now? It is 6%. How will you proceed now?
So if there is obstruction at the PUJ, so we can't assess the function at this time. So I would like to do a TCN first, then we'll reassess after 1 month or so.
Sir, Professor Anmesh Das and Professor Anjit Das, sir, please.
You see, in CT scan, there is thinned out parenchyma, and whatever parenchyma is there, there are like access like collections. And DTP already showed GFR 3. So do you think with PCN it will improve? It is very much theoretical approach. It will not improve. So second thing is that you have to stabilize the patient, you have to treat infection, control the diabetes, then you have to consider nephrectomy. The reason is that it is the XGP. Well, your diagnosis is well, but clinically, most of the time it appears to be renal tumor. And truly, pathologically also, there are some association of RCC, PCC pelvis, even squamous cell carcinoma. So it is virtually a infected, non-functioning kidney. You have to remove it. But after some time, after stabilizing the patient.
Sir rightly said, XGP is a destructive disease for the kidney. Once you diagnose XGP, there is no way you can say that there is very little chance that kidney can be saved or it can be improved. It cannot be improved by any means by stenting or so you have to plan for nephrectomy. If you have diagnosed XGP, you have to plan for nephrectomy. You have to go ahead with that after stabilization of the patient. Sir, I think the case discussion is over. If any more question you want to ask, you can. Otherwise, I will.
The postgraduates, have you seen any case of XGP? Have you seen any case of XGP?
No, sir, not till now.
I've seen, sir.
I have seen, sir.
So XGP, it is basically an inflammatory process, but the inflammatory and fibrosis in the kidney and the perirenal areas is tremendous.
Infiltrating inflammatory process.
It is almost, when you go to operate, it is almost a cemented kidney with no tissue planes, and in a carcinoma, in a malignancy, you will be able to find a tissue plane somewhere or the other. But in an XGP, there is no tissue planes. And it is a very difficult surgery. In fact, XGP surgery is much more difficult than a malignant surgery on a malignant kidney. So that is what you should remember during, if you are taking a surgical step, if we are going for a nephrectomy.
And another point I want to highlight, clinically, it is very difficult to diagnose XGP. Usually, our first diagnosis is the renal tumor because kidney is somewhat palpable. Maybe surface is smooth. So in DD, it might come. So always it is first diagnosis is the renal tumor. Then after investigation, you will proceed and you will realize, oh, it could be an XGP. So, okay.
The enhancement is less. The
yes.
enhancement in an XGP is much less than in a RCC. Usually, it is 1 point, and the inflammatory point is also gives some indication that it may be an infective process. Anyway, the two are very closely imitates each other, and one should be careful. Thank you.
Okay, with this, we have come to the end of our discussion. Well, in time, we have been allotted 10 to 12 for our case discussions. We have come right at time to the end of our case discussion schedule. We have discussed 3 cases. Now, for me, it was very difficult to discuss GUTB in its entirety. GUTB is such a varied disease, such a varied condition, and it presents with so many other things it can present with that we cannot discuss it in a time of 1 hour only. So I have prepared a slide of a few some slides of a few other cases of GUTB just to enumerate, just to show and just to give you an idea how GUTB can present in different forms. It can involve the genitourinary tract right from the kidney up to the tip of the penis. All the organs, all the parts of the genitourinary system can be involved by tuberculosis, and it is a varied pathology. So we must know about it. We must be vigilant enough. We must have an index of suspicion always in any chronic symptomatology. So to have a conclusion, I am sharing this. Epidemiologically, it is still prevalent in large numbers in developing countries. Genitourinary TB, as I already told, may present as involvement of anything right from the kidney up to the tip of the penis, and there should be a low index of suspicion, which is must for the diagnosis, as presentation can be very much varied. So the diagnostic criteria for the diagnosis of GUTB are very well defined. One major criteria, presence of one major criteria or 2 minor criteria are good enough for the diagnosis of GUTB. The major criteria includes a granulomatous lesion on histopathology with heavy positivity in urine, or a histopathology or positive PCR report. Minor criteria, the changes which are suggestive of TB on IVU or CT scan, hematuria, presence of hematuria, presence of a raised ESR or pulmonary changes. These are the minor criteria for the diagnosis. We must know these days about the drug-resistant TB, as it is a very common and very problematic situation when we deal with drug-resistant TB. So it is classified into various groups according to how the tubercular bacilli is resistant to which drugs. So the monoresistant TB is when the bacilli is resistant to only one first-line drug. The polydrug resistant TB is when this resistance is extended to more than one first-line drug. But these two drugs are not H and R, that is not isoniazid and rifampicin. If a tubercle bacilli is resistant to both isoniazid and rifampicin simultaneously, it becomes an MDR TB. That is multi-drug resistant. And when extended extensive drug resistance, XDR TB, it is the MDR TB with plus resistance to one of the fluoroquinolones or the second line injectable agent. So this must be known. And these days we are dealing very much with XDR and MDR TB, and this is creating too many problems in our TB control programs. Coming to different presentations that we can have here in this image, you can see a kidney which was removed, which is showing multiple case-gating necrosis and tuberculoma formation all over the renal parenchyma. This is one presentation that we can have multiple tubercular abscesses in the kidney, in the cortical abscesses, in medullary abscesses, all those things. This is another one kidney, the gut section, which showing case-gating necrosis all around the cortex and medulla in the kidney. This is a typical picture of a putty kidney where a case-gating material is present all inside the renal parenchyma and collecting system. Another image showing a completely calcified autonephrectomized kidney with putty kidney. This is an IVU showing on the left side. You can see the north eastern appearance of calyces, and the superior white arrow is showing a phantom calyx. Looks like there should be a calyx present there, but it is not visualized. This is what phantom calyx is. And along with this, you can also see a stricture in the lower ureter. So it may present with anything, right from the involvement of the calyces to the involvement of the lower ureter, bladder, or any present. This is another a good example of showing multiple small calcifications all down in the right kidney, along with calcification in the line of the right upper ureter as well. So, and it is non-functioning. The contrast is not being excreted in this IVU. This is another example showing on the left side left. You can see a superior ventral calyx is present. So the black solid arrow is showing that. This is a horseshoe kidney with left side left moiety calcification and the right moiety draining to the urine. This functioning. Here you can see an autonephrectomy with calcifications in the parenchyma and the kidney is completely atrophied. This is cystoscopy finding the finding of the ureter. When the ureter is involved, the lower UJ is involved or ureter is involved. You can see the gold pole ureter here clearly. This is one example again of thimble bladder. Thimble bladder with VUR. Here you can see both side ureter is dilated and there is a bladder capacity is very low. Here you can see calcifications involving both of seminal vesicles. You can see the calcification in the pelvic region. These are the calcifications of seminal vesicle. It is one of the organs involved by PV. This is a cut specimen of an epididymoorchitis, tubercular orchitis. It's just showing caseous necrosis site. This is one involvement of a penis. You can see a subcutaneous swelling. This on FNAG showed granulomatous inflammation. This can be one of the presentations of genitourinary. These are the various presentations. So the idea is to tell you about how varied the presentation of tuberculosis may be in TB cases. So as to have a differential diagnosis of TB in almost all the presentations when you are getting a patient who has a chronic illness, the differential diagnosis of TB has to be there always. It's always there. It may always present with something. Okay, now for the next session, there is a presentation I will be presenting on interstitial cystitis and bladder pain syndrome. Yes.
Dr. Ashu.
Sir, please go ahead.
I should make some analysis. Should I do it now or after your presentation?
Sir, you can do. There is one more presentation on interstitial cystitis. You can add that also.
Okay, please come.
Yes. The screen is visible to everybody. So interstitial cystitis or bladder pain syndrome is not a very common but not also very rare presentation that the patients come to us, and it is a very difficult disease to diagnose. In fact, it is a case most of the time it is a best basket diagnosis where none other diagnoses are clear. So we label the patient with having interstitial cystitis, which is a very difficult condition to diagnose and treat as well. So I would like to give you some gist about interstitial cystitis in this presentation in the next 15-20 minutes. So I will start with a simple presentation of a case. A 30 years old lady who complains of symptoms like frequency, increased frequency, sometimes having nocturia, lower abdominal discomfort, and all of these symptoms are there for last 6 months. What could be the diagnosis? The first things that come with increased frequency nocturia in a 30-year-old lady that comes in our mind, the first two things are either UTI or overactive bladder. So coming to overactive bladder, is it overactive bladder? We have to make in any case where the patient is present, as Dr. Ranveer sir also said while we were presenting the GUTB case, in any patient who presents with with storage LUTs, with storage LUTS, bladder diary, avoiding diary is a must. It gives you a lot of ideas regarding the frequency, regarding the amount of urine each time the patient is passing, and many other ideas that you can get from a simple bladder diary. So bladder diary was made and the number of voids was 8 in a day. There were no incontinence episodes. Incontinent episodes are very common in overactive bladder. Patient has an urge to void. Urge cannot be controlled, and while the patient is running to the washroom, few drops of urine always uh, dribble out. So in absence of incontinence episodes, you should question your diagnosis of overactive bladder. You should always, in any case, in any patient presenting with the storage fluids with increased frequency, you should always take the history of amount of fluid that the patient is taking in, because many a times patient presents with polydipsia, is taking much more water and is having increased frequency of urination due to that psychogenic polydipsia, and all those patients will be getting in your OPDs, and these will be presenting to you with increased frequency. But actually, the problem is that they have high abnormal intake of water. So we should take that into account in history as well. And it has, in this case, it was adequate. It was not excessive. After that, in all the cases with increased frequency, antimuscarinics are prescribed. This patient did not improve on antimuscarinic, and this questions your diagnosis of overactive bladder. Overactive bladder usually responds very well to antimuscarinic. So overactive bladder is still a question mark in this patient. Coming to UTI, the urine analysis, there is no pus cells was there, RBCs were not there, urine culture was negative, and even antibiotics, empirical antibiotics were given, but symptoms were not improved. So these 3 points exclude the diagnosis of UTI as well. So the two most common diseases that you could think of was UTI and overactive bladder. Both of them are excluded. What next? So in comes the diagnosis of interstitial cystitis or bladder pain syndrome. Now, what more in history do we want to label this patient having interstitial cystitis? So very important point is that it is associated with a pain which increases on bladder filling. Once the patient has a full bladder, there will be a pain or discomfort, a suprapubic discomfort, and this discomfort or pain, whatever that is, will get relieved once the patient voids. This is a very classical symptom of interstitial cystitis, and it needs to be differentiated very well. The patient, what the patient is saying, this is very important. In overactive bladder, once the bladder gets filled, the patient gets an urge to void, and the urgency is decreased after voiding. In interstitial cystitis, it is not the urge, it is a feeling of fullness or pain or discomfort or throbbing sensation in the suprapubic region. So we have to differentiate between pain and the urge to void, to diagnose, differentiate between overactive bladder and interstitial cystitis. Along with it, a very important part in history in interstitial cystitis is that it is aggravated by certain foods, especially some spicy foods. So we have to take a history that you eat something which is spicy, does your symptoms get aggravated after that? If the patient is saying yes, you should think of a diagnosis of interstitial cystitis. Coming to the better understanding of the disease, which must know some historical background about the disease. This was first described in a text in 1836. In 1876, the term interstitial cystitis was coined by Dr. Samuel Cross. The Hunner ulcers or Hunner lesions, which were thought of to be pathognomonic of this disease, were first described by Hunner in 1915 to 1910s. And the petechial hemorrhage, the glomerulations, that what we call nowadays, was first described was by hand in 1949, but the term glomerulation was coined way later in 1978 by Patrick Walsh. Coming to the definition, the American Urological Association in its guidelines has clearly defined interstitial cystitis or bladder pain syndrome as an unpleasant sensation. This unpleasant sensation may be pain, pressure, or discomfort, which is perceived to be related to the urinary bladder associated with lower urinary tract symptoms of more than 6 weeks duration. And there has to be an absence of infection or other identifiable causes. So in the definition itself, it is written that it is a West basket diagnosis. When you cannot diagnose anything else, it is interstitial cystitis. In June 29, the Indian BPS Society came up with its own guidelines on interstitial cystitis, and it defined it as a recurrent pelvic pain or discomfort, that is pressure, burning, throbbing, etc., of at least 4 to 6 weeks duration. The duration, as was in AU, is 6 weeks. Here we can diagnose it with 4 to 6 weeks also. It increases with bladder filling and or decreases with maturation in the absence of definable pathology associated with urinary frequency and or urgency. So it is very important. You see in both the definitions, the absence of any other pathology is very important to diagnose interstitial cystitis. Coming to the prevalence, it was almost 25 to 30 years back, it was believed that interstitial cystitis does not exist in India. But today, it is well known that it is a disease which is present in India also, and there are quite million patients, over 1.25 million patients suffering from ICBPS in our country as well. And you will see in your OPDs also that although the disease can affect both sexes, approximately 90% patients are female. The predilection why it is there is not known, but it is very clear that it is there. Coming to the natural history of the disease, so if you take the history of the patient completely, you will see that there was some prodromal symptoms which were related to pelvic pain and irritative voiding, which were experienced decades before a formal diagnosis was made. The patient will tell that it is coming back from a very long time. So you have to ask that also. Symptoms tend to fluctuate over time. It decreases, it aggravates. With majority of patients, they don't show any long-term deterioration. They will continue feeling like same with the disease. With time, the symptoms don't deteriorate. It affects you a lot, but it does not deteriorate. The flares are common and mostly which are experienced for several days. Triggers for flares, as I already said, some spicy food or something else are very widely known among patients. And for each patient, the flare trigger for flare may be something different. So we have to ask the patient clearly that do you think that your symptoms get flared up by doing something, by eating some special food, and you have to avoid management. The quality of life is always affected. It is significantly affected. I'll come to later also why it is affected, on what ground it is affected, but it is significantly affected on all domains. And the ability to function effectively or at all in the workplace is also affected, reducing the productivity of the patient completely. Coming to the impact on fuel, as I already told, the patient is not able to sleep properly due to increased frequencies of sleep disturbances are there, which affects the mental health, physical health, as well as work productivity at the office. There is decreased work activity and it affects your sexual life as well. So all these things leading to decreased quality of life and causing mental health issues also, affecting your psychological health and causing anxiety, depression, and other mental health issues. So it significantly affects your quality of life. Coming to the etiopathogenesis, the exact etiology is still unknown, but it is said to be multifactorial. Pathogenesis in pathology, it starts with some sort of bladder insult. How it happens, why it happens, we don't know, but it starts with some sort of bladder insult. What it causes damage to the epithelial layer of the bladder, which leads to the leakage of potassium into the interstitium. This potassium leak into the interstitium activates the C fibers and the release of substance P, which are the cause of all the symptoms, most of the symptoms, and it activates the mast cell and release of histamine, which further cause more injury and more activation of C fibers causing a vicious cycle, and this more injury causing more bladder insult, and this vicious cycle is completed and the pathogenesis goes on. Coming to the pathology, mast cell and histamine are very important here. The leakage of mast cell and the release of histamine, as we already said, it activates the C fibers and the substance P, which causes most of the symptoms. The glycosaminoglycan layers in the bladder epithelium and the epithelial permeability to the sodium and potassium is very important. If it decreases, the GAG layer in the bladder epithelium is basically a protective layer. It protects against bladder insult. If it depletes, it increases the permeability of the epithelium to the electrolytes, to sodium and potassium, and this potassium may lead to problems as we already seen in the flowchart. This last slide. Coming to the differential diagnosis, I have already uttered so many times. It can be confused with so many other diagnoses. Most importantly, overactive bladder tract infection, pelvic floor dysfunction, radiation cystitis, carcinoma in situ may present in the same way. A bladder stone may present in the same way. History of chemotherapy or ketamine cystitis may also be there. So these are the differential diagnoses from which this condition needs to be differentiated. Coming to how do we make the diagnosis? The basic assessment should include a careful history. I already said the importance of history cannot be undermined. It has to be taken and properly taken with all the points that I already said. Physical examination is usually unremarkable in these cases, and laboratory examination, and mainly physical examination, laboratory examination are there to rule out other causes of the same symptoms. Baseline voiding symptoms and pain levels should be obtained in order to measure subsequent treatment effects. Cystoscopy or urodynamics should be considered as an aid to diagnosis only. It is not diagnostic, and it is to be done in complex presentations only. It is recommended that it should be done in complex presentations only. These tests are not necessary routinely for making the diagnosis in uncomplicated presentations. Coming to the investigations, urinalysis and culture is important to rule out UTI. And here also we must know that it is not that interstitial cystitis cannot be there with UTI. UTI may be there as a secondary or super infection in patients with interstitial cystitis, but not symptoms not getting controlled with appropriate and proper antibiotic therapy. We must keep in mind the diagnosis of ICS. Avoiding diary patients usually voids frequently with small volume of urine with pain mainly as the trigger for micturition. USG is usually normal, and intravesical potassium sensitivity test was used, but it is not recommended now as it causes severe symptoms and the patient may be able to take it rather. Coming to the cystoscopy, I already said it is not routinely indicated, but the objectives are to look for lesions of interstitial cystitis like Hunner's lesions or glomerulations. The capacity of bladder has to be ascertained. Patients with normal capacity may also have IC. This should be kept in mind. The other objective of cystoscopy is to rule out other diagnoses like bladder stone, presence of CIS, bladder cancer, or other things for which we may need a biopsy to confirm. The treatment also can be done with hydrodistension during cystoscopy. So these are the objectives of cystoscopy. This is a picture showing glomerulations. These are tiny petechial hemorrhage which is shown when the bladder is over distended. These are 100 lesions which were seen, which were thought of to be pathognomonic of interstitial cystitis, but nowadays the presence of 100 lesions is not required for the diagnosis. Comes the grading, we are Copenhagen cystoscopic classification of bladder mucosa is there, in which the grade 0 is a normal mucosa, grade 1 is petechia in at least 2 quadrants, grade 2 is large submucosal bleeding causing chymosis, grade 3 is diffuse global mucosal bleeding, and grade 4 is mucosal disruption with or without bleeding or edema. Coming now to the treatment of this condition, the treatment strategies should proceed using more conservative therapies first. As in all the benign cases, we have to think of something minimally invasive, non-invasive or minimally invasive first, then going to invasive therapy. So should start with conservative therapy only. Initial treatment type and level should depend on the symptom severity. How severe the symptoms are, we should ascertain, and accordingly we should plan for the treatment of what we are going to do the patient with. Multiple simultaneous treatments may be considered if it is in the best interest of the patient. And because of their irreversibility, surgical treatments like other than fulguration of under lesions are appropriate only after other treatment alternatives have been exhausted. The ineffective treatment should be stopped once a clinically meaningful interval has elapsed. The diagnosis should be reconsidered if no improvement occurs after multiple treatment approach. This is the AUA suggested treatment lines. The first line treatment always starts with behavioral modifications and general relaxation, stress management, and pain management. Behavioral modification, we have to reduce the fluid intake. We have to reduce the intake of such foods which are triggering the flare of responses. We have to educate the patient regarding these symptoms. The second line, we can use some oral agents like amitriptyline, hydroxyzine, simvastatin, or polysulfate sodium. Intravesical therapy, heparin, lidocaine can be used. In third line, we can use the cystoscopy under anesthesia with hydrodistension and treatment of anal lesion, that is fulguration of anal lesions if found. In the fourth line, Botox can be used, or sacral neuromodulation can be used. In fifth line, cyclosporine is advised. The sixth line treatment constitutes the surgical treatment of this condition in the form of urinary diversion with or without cystectomy or substitution cystoplasty. According to the Indian guidelines, it is almost similar to the American guidelines, and a stage treatment policy has been the standard approach in the Indian guideline as well. In comparison to EU guidelines, it was found that intravesical Botox is not very much effective, so it has been removed from the protocol. And behavior modification and stress management are still the first line treatments and the most important things in the guidelines. Coming to individual points, hydrodistension of the bladder is done under anesthesia. It's technically a surgical treatment, but often the first therapeutic modality employed, often as a part of diagnostic evaluation and cystoscopy. Hydrodistension is done at catheter. An initial cystoscopy examination is performed to obtain urine for cytology and distend the bladder for 1 to 2 minutes at a pressure of 80 centimeters of water. The bladder is emptied and then refilled to allow observation for fluctuations or ulceration. Therapeutic hydraulic distension follows for another 8 minutes. Biopsy, if indicated, if you are going to take biopsy, is performed after the second distension. The sodium pentosan polysulfate is an oral medication, and it is only oral medication for this condition which is approved by the US FDA. This most widely accepted mechanism of action of the drug is the repair of the glycosaminoglycan layer. The main drawback of this drug is that only 1 to 3% of the drug reaches the bladder, resulting in a long course of treatment of approximately 3 to 6 months. It is a costly drug. Adverse effects may include alopecia, diarrhea, nausea, and rash. Rare bleeding problems have also been reported. Coming to the use of antidepressants and NSAIDs, these are mainly for pain management, and combination therapies are effective in treating chronic pain. Amitriptyline and tricyclic antidepressant is the most common antidepressant which is used in these treatments. Intravesical glycosaminoglycan it induces the production of intravesical hyaluronic acid, a substance that blocks the action of lytic enzymes and stimulates proteoglycan synthesis by inducing increased hyaluronic acid levels, the reconstituting the This is basically about reconstituting the urothelium, the reversing the initial bladder insult that has initiated the whole process. So this has been shown to be somewhat useful. Hydrodistension with 20 ml of saline associated with 2% chondroitin sulfate. It showed an improvement of an urgency of around 47% and decrease in burning frequency by 51%. It may also be combined with lidocaine for immediate pain relief. Otherwise, immediate pain relief is not there, and we take some time for its effects to come. Coming to oxybutynin, it is an anticholinergic drug, a special antispasmodic drug, which has a local anesthetic effect also. So it decreases pain, it decreases bladder contraction, so the symptoms are controlled. BCG vaccine is a live SLI. We already know it is widely used in the treatment of bladder cancer. First time Peter performed bladder installation in women with PPS IC. The study used bladder hydrodistension as the control treatment, and in the treatment group, a 67% improvement in pain was observed, whereas in the control group, only 27% improvement in pain was observed. Still, it is not recommended according to any guidelines till date. Botox, as I already told, is included in the AUA guidelines, but in Indian guidelines, they have said that it does not have a significant effect on the symptomatology. So, in Indian guidelines, Botox is not recommended. Coming to sacral neuromodulation, it is an alternative therapy for patients with voiding dysfunction. The purpose is to inhibit the detrusor action by the electrical stimulation of sacral nerve fibers via subcutaneous electrode implanted in the region of S3 vertebra. The justification for this treatment is based on the existence of a spinal inhibitory systems which are able to stop the contraction of the detrusor muscle, thus decreasing the frequency. Other agents are all are within studies only, so it is recommended very clearly for this condition. Coming to the take-home message, it is a infectious cystitis is well prevalent in India but often misdiagnosed. Pathophysiology is complex; it needs multimodal treatment approach. Sequential treatment approach starting with conservative management to oral, intravesical, intraretrosal, and surgical approach in a sequential manner is recommended. Pentosan polysulfate sodium is the only FDA-approved oral drug in the treatment of IC. Treatment with antidepressants and proper pain management is needed to significantly improve the quality of life. Thank you. With this, I have come to the end of this presentation. So, Dr. Ranjit Das, sir, you can take over.
Thank you, Dr. Ashu.
Sir.
What I want to say in the end to the boys, out of all the three cases, genitourinary tuberculosis, first thing you have realized it's a very vast subject. Second thing, you are sure to get question both in theory and in practical also. So you have to know each and everything of the GUTB. Coming to our today's case discussion, it is usual practice whenever a case is being presented to you during exam, after the clinical features, you will be asked to give your impression. That is differential diagnosis. Here also, after presentation of the clinical features, you have been asked to DD. Yes, you have said all the things. I am not sure. Probably neurogenic bladder you have not added. Bladder stone you should say. If the age is more, then BPH, CA prostate should be included. And other things you have mentioned today. So next thing, you have been asked in sterile pyuria. Once you have uttered the word, sir, it is sterile pyuria, automatically you will be asked what are the causes of sterile pyuria. I mean, today, Professor Onimus has asked me. So you have answered rightly everything. One thing I will add, this is the presence of foreign body. Most common foreign body urology is the digestion. Next, proceeding towards the investigation, you will be asked to proceed. After urine analysis, after the blood biochemistry, here the boys I have seen fumble because your first diagnosis is GUTB. So what to do? Urine for FB, all are very hesitant. I think here you uttered the three things. First you say, I will send the urine again, whether it is the first void urine or it is the overnight collection, you have to decide from the clinical presentation. If there is extreme frequency, then first void urine will be very small amount. So here you have to say, sir, overnight collection. Or if there is not much frequency, you can say the first void. So what is the minimum amount of urine required? Minimum is 50 cc. So what you'll say, you'll see accordingly, overnight collection. I'll send for AFB staining, AFB culture, and for PCR nuts. I think in a single breath, you tell all three. Examiner will next, obviously, will discuss about the what is the AFB staining. As Professor Dasu was asking you, you must know the steps of AFB staining because all basic things you have to know. So AFB staining steps you should know. Next, you will be asked, what culture do you advise? You know there are 2-3 cultures, 2 solid media, 1 liquid media. So which one you will prefer? Again, it is up to you to say what. I think you will say, sir, I will prefer for the liquid media, but it bears some, it is costly because liquid media culture is usually not available at least in government hospitals, what I know. So you'll say you prefer for the liquid media. The examiner will ask about the solid medias. That is what is called. Sorry, Jensen. LJ media. What is LJ media? What is the then what is the agar media? And I am sure you will be asked the principles of backtrack culture. You must know the principles of backtrack culture. You will learn it. You will be asked. Diagnosis, proceed for the investigations. Ultrasonogram will give you some idea, and you have rightly asked for the NCCT today. Because when due to high creatinine, we cannot do the CCT, it is advisable to get an NCCT. Most of the anatomical outlines, we can have an idea. So, what are the confusion was there? Oh, then came the treatment. Again, I will tell you, examiner will tell you, AFB staining negative, culture negative, what you will do. Don't get confused. Here comes what Dr. Ashu has mentioned in his talk. There is the major criteria and the minor criteria. You look into the minor criteria, then does not it fit with the major criteria. And for minor criteria, another thing I must congratulate the boy who told the MCU. Yes, once in ultrasonogram we have seen the left is grossly dilated ureter and the pelvic ileation system dilated. Right kidney is cystic changes, means virtually it is non-functioning. By looking at the ultrasonogram, we can assume, don't say. So BCG will give you one thing, idea about the bladder and whether the ureter is, user of the left side is obstructed or reflux. This idea you will get. And it will be another radiological evidence as a minor factor in diagnosis. So what else I want to say? Another thing we have not discussed today. Sometimes students say, sir, when a student is asked, say all cultures, FD, everything is negative. So student says, sir, I will do cystoscopic biopsy. This is again not to be a right answer. Cystoscopy, again, the scope of biopsy is very limited because biopsy sensitivity is about 30 to 40%, even less. Moreover, difficult, and only it is done when I have got confusion to exclude the malignancies and some rarer situations. So, as a flowchart, biopsy does not come. Next, I have seen one thing. I will be a bit deviate from others. Here you have seen the left side is grossly grade 4 reflux. The right side is, it appears obstructed somewhere in the PVJ area due to scarring, might be. So to save the left kidney, many of you told that I will do the PCL. Question of drainage comes when the system is obstructed. If anyone tells I will do PC on the right side, I do not have much to object. But left side PCN, I am obviously seeing it is not obstructed system. Yes, in anticipation of starting ATD, it might be obstructed later on due to the fibrosis and stricture. This is another thing. In anticipation, I should not go for the drainage. I will do that, start the treatment, and periodically, at least 2 weekly, I will do the ultrasonogram screening and creatinine. I follow up. If I find system is obstructed, I will do the drainage. This is one point which I want to say. Second thing is that whether PCN or degestanting, I'm not telling you to do degestanting or PCN in this case. I'm just telling you on principle. Degestanting is preferred. PCN, when degestanting fails, you have to go for the PCN. Reason being, PCN, once you commit a PCN, you have to do some reconstructive surgery or nephrectomy in that site. Otherwise, it will give you a fistula. A bit controversial words I've told you because I differed on this. Another point I want to tell you, during surgery, again, sorry sir, I beg apology, I am differing from others. Question is, when you do augmentation, we have to do the reimplantation. Before reimplantation, we have to see whether it is a refluxing or it is a obstructive ureter. If obstructive, there is no other way. I have to do reimplant. But if refluxing, we do usually, at least myself, we do not go for the reimplantation. Reason being, this area, lower ureter, is grossly fibrosed, vascularity very poor. So there is a high chance of failure or implantation. So I personally say or feel I do not take any risk of doing implantation because it is a, if you do cystoscopy in this case, I am sure you will find it is a golf hole ureter. Yes, reflux will persist, but once you have made a bigger bladder and if it remains infection free, then this reflux will probably not cause any problem. Another thing I want to tell you, basic creatinine was 2.67. So I know one boy has rightly mentioned, sir, I will go for the ileal conduit. But practically no one wants to go for ileal conduit in a very young man. Augmentation has got some complications. It might go in a high creatinine. It might slowly cause renal damage. There are many mechanisms. So here I want to, at least it is my personal view, I want to try to reduce the creatinine. And this is, I might, because once I started the anti-tubercular drug, I have to wait for 6 weeks minimum. So I might put the patient on catheter. Again, a controversial statement I'm making. So if I make the equipment, then there will be no reflux. There will be no reflux, and there might be some reduction in creatinine. I am not sure, but I may give a trial for that. If I keep it for a patient catheter for these 6 weeks, and I can see whether creatinine is coming down or not. So I think there will be no harm. And the reason is that someone will say that reflux will not cause any renal damage, but reflux does not cause renal damage in adult, but if there is a stasis of urine, it causes renal damage. Here, renal damage is due to one is tuberculosis, another is the stasis, because the pelvic ileal system, ureter and bladder became the same pot. So this stasis is causing the renal damage. There are many things to be told about the cystoscopy follow-up. Like anyway, I've forgotten the point. Most of the confusing problems I have uttered, but as a student, you must know everything. You must know the treatment about the drugs, particularly newer drugs. This might come as a short notes. That is your what is called bedaquiline, delinamide. This might come as short notes, and you will be asked about the adverse reaction to the drugs. In augmentation, again, yes, theoretically it is obvious because if you do ileal augmentation, then there may be an maybe some it is not being preferred, maybe some complications, sigmoid or ileocycloplasty may be preferred. But what I want to tell you, always follow what your teachers are doing. What Professor Animesh Das asked, told, this is the thing. Always follow what your teachers are doing, practicing, and you are familiar with that technique, you say that. Because, again, I tell you, in our urological career, many cases of whatever augmentation we have done for the tuberculosis, we have done with the ileum. Somehow it has become the tradition, probably. I have learned it from my teacher. I am doing it. My students are also probably doing it. So if this is so, you have seen it, then tell what your teacher says, what you have seen. If you have not seen it, you do not know, then you can go for the theoretical one. There are further things, other complications and follow-up. These things will be asked. So I think these are the mostly for the GUTB. Next comes the case of EPN. You see, out of these clinical cases, 2 are almost straightforward, very little to discuss, but tuberculosis was never ending. You have realized, and there are many, at least 7, 8 classes can be done. So you have to know the presentations, genitourinary tuberculosis presentations. Details you have to know. There are many things to be done. Next case was a EPN. Again, EPN is very nicely covered. The thing, if at all you get a case, short case or wardroom, then prognostication is the classification you will be asked definitely. It is the important. And second thing is the drainage. Do not hesitate to say not only PC and it is a catheter drainage, percutaneous catheter drainage, and if required, sir, multiple. Or another thing is the functional study in EPN that you can do, but not now. Let the patient get stabilized. If not stabilized, you will go for the nephrectomy. No need to go for the functional study. Functional should be done. If conservative patient responds, then say after 1 or 1.5 months, and you have to consider delayed nephrectomy. Most of the patient, in fact, requires delayed nephrectomy. So I have nothing to say from the for EPN. Next was the Xanthogramma pyloritis. I have told you, it is directly no patient comes with the diagnosis. Mostly it is clinically confused with the renal tumor. After investigation, you realize there is a stone, there is a chronic infection, there is a debris inside. So clinically you think, oh yes, it is a Xanthogramma pyloritis. Treatment is, and most of them most of them are either non-functioning or very poorly functioning. And thanks to the nature, usually it occurs in the one side. So nephrectomy is the nephrectomy, or if a segment is involved, segmental nephrectomy is the answer. And last is the bladder pain syndrome. Dr. Ongshuman, this is a very complex and vast subject. There is no scope of it is be considered in the practical examination, but there is a high chance you will get theory questions from this chapter. Pathology, pathogenesis, diagnosis, outline the management. So these are many things can come in the theory. Dr. Okshuman has covered very nicely. This an irritability, I must say, this subject, I have nothing to comment. Thank you. Thank you, Professor Onimesh Das. Thank you, Dr. Ashu. Thank you, boys.
Thank you. One point I would like to say to the students, we were given a list of 4 students to participate here, but this is not an examination. This is a platform where you have to learn things, how you do in your examination. You have to learn that. It's just a preparation. So you don't have to fear. You don't have to have fear about anything here in these classes, in these online classes. This is just the second class of this year. And in the next coming months, we will be having more classes. You have to participate more. You have to come forward and answer the questions so as to you are able to answer when it really matters, that is in your final exit examinations. This is just a practice for that, so don't hesitate, don't get fearful about anything. We are not here to scold you or anything like that. We are here to help you. Dr. Ranjan Desar has planned these classes last year also, this year also, in such a way that we will be covering all the topics completely over the next 1.5 months approx. And this is very helpful for you. We didn't get such a class in our time. We had to just to somehow manage our exit examination. Sir was himself an examiner there in my exit examination. And we know how it was so difficult for us. But for you people, you have got the chance to prepare for your examinations. So come forward on yourself and participate as much as possible in these examinations. Thank you. Dr. Ranjan Desar.
Thank you. I don't know whether I should thank or I should congratulate. I must congratulate my students first for their attention they have given to get a fantastic answers in many of the situations. And of course, to the senior teachers, observers, and the moderator. I am really thankful to all of you for giving an excellent presentation for the students. And for the students, my advice for so many years in the teaching, I have found that in spite of knowing the fact very well, even better than the teachers during examination, students cannot express themselves. This platform has been created so that they get an opportunity to express themselves without any fear. That will give them more confidence during their real examination. So I will request them to utilize this. I especially thank Dr. Joy, who was in Edinburgh and called me in the early morning so that he can be excused at 11:30, 12 because the flight. Still, he has participated. Dr. Sanjay Chaudhary, Professor Onimesh Das, and everyone, those who are present, many seniors. I also saw a few minutes back, Dr. Sudip Charan Chakraborty was online. Sudip, Dr. Chakraborty, if you are online, if you have few lines to say, you are welcome, sir, if you are still in the platform.
I don't know whether I am audible or not because
yes, sir, you are audible. You are audible.
Because I'm just managing with my cell phone only, and I'm not very. I'm not an expert as regarding all these technologies. And anyway, I enjoyed. I'm sorry that I missed it earlier part because I couldn't manage. But I found that this has been really very much educative consecutive, not only for the students, but also for all of us, I think. And every day newer things are coming. And so in order to keep pace with the changes, all of us must be interested. And my request is to all my colleagues, senior colleagues, and everybody, we should participate as much as possible. And I will always try to be there as a listener. I don't like to say anything. I have nothing much to add or say. So genital and tuberculosis, as Professor Das has elaborately discussed, and this is the most important. And for students, yes, at least in examination, prepare genitourinary tuberculosis. You are going to get it in some form or other, and you must know thoroughly about everything. So that's the thing. It has been nicely, very nicely presented. Angshu has presented interstitial cystitis very nicely. I was a little late in joining. Please forgive me. I'll be
Thank
there. I
you.
will try to be there every time. Thank you.
Thank you, sir. Next weekend, there are a lot of requests from different parts of our country, so that there will be a huge workshop on laparoscopy. Many of the teachers are going to participate in that laparoscopic workshop. That is why our next class will be on 8th and 9th April, that weekend. 1st and 2nd, we are not organizing any class. 8th, 9th, there will be classes on renal cell carcinoma, renal mass, and Dr. Kalyan Kumar Sarkar will be the moderator. Hope that is also another very important topic, and you all will participate and actively utilize the platform which has been created on behalf of the EZUSI USI. And I am giving you good news. National body is observing our class. Dr. Arun Chawla called me yesterday. Today he was observing how we are planned this program, how the students are performing. He may introduce it in future, very near future, in the national forum in this format. With this good news, I thank all of you once again and say bye, to meet you once again in this platform on 8th of April 2023. Thank you, sir. Yes, sir. Yes.
One thing, I'm sorry, don't take it otherwise.
No,
15th April is the Poila Boishak evening.
no, 8th, 9th.
For me, I think we have one, I have been kept as an observation, something like that. 15th April, that is Poila Boishak. Lot of
Oh,
evening programs are 15th April.
okay, sir. Okay. I
See,
understand, sir.
check. Okay.
I will take a note. We'll have to.
As you know, I am little bit interested outside urology.
Okay.
Sorry.
Okay.
It's
Okay.
okay. No.
Thank you. Thank you. Thank you, everybody. Thank you very much for participation. Bye. Thank you, Oshu.
Bye.
Asu. Bye.
Thank you very much.
Thank you. Welcome.